Dr. Spees, have you tried your mic?
I have. I'm working well. Good
Okay,
morning. How are you?
perfect. How are you?
I'm wonderful.
Great,
Awake and
great,
functional, ready to go.
great. Thank you.
Morning, everyone.
Good morning.
Hello, hello, hello. Good morning, good afternoon, good evening, everybody, depending on what country you're joining us from. Today, we're welcoming you to the 11th annual scientific conference of the Bloodless Medicine and Surgery Society. It's so good to be here again, and we're trusting that it's going to be an exciting experience. It's going to be educative, and trust me, you don't want to miss it. So, thank you for joining us. My name is Dr. Uduak Koli, and I'm going to be one of the moderators for today. Okay, so just before we step into the business of the day, for those of us who are joining us for the first time, what is Bloodless Medicine and Surgery Society? You might be wondering. Okay, so it's an national multidisciplinary society. It comprises of experts from various fields that are interested in the avoidance of blood transfusion, okay, whether it be surgery or medicine. And the aim is to ensure that we have excellent patient outcome and maintain the rights of our patients. That is the highlight of the Bloodless Medicine and Surgery Society. All right, and we usually hold these conferences every year, and today's the 11th edition, and the theme is very interesting. It's technology and bloodless medicine, of course. So we have technology coming in, taking it's the order of the day. So why not blood surgery and medicine just has to pitch in and get on the trend and do things. Try to bring in a little bit of technology, if you know what I mean. So today it's going to be exciting. We're going to be having wonderful, amazing speakers with us, and I'm sure you don't want to miss it. All right, so it's going to be a 3-day event. We're starting today, and we're going to be running till the 7th of November. So we're going to be running 7 a.m. Eastern Standard Time, 12 p.m. GMT, of course, 1 p.m. for the West African time. And if you're in Malaysia, it's 8 p.m. your time. It's so good to be here with you. And at this point, I'm going to be introducing my co-moderators because I'm not going to be doing this alone, okay? All right, so I have with me one of the moderators, Dr. Nathaniel Usora, my own teacher. and he's at the same time the immediate past president of the Bloodless Medicine and Surgery Society. He is the chief consultant surgeon, head of Bloodless Surgery Unit, University of Calabar Teaching Hospital. Dr. Nathaniel, sorry, you're welcome, sir.
Thank you, Edward. Hello, everyone. Happy to be here.
Good, good, good. And also, I have with me Mary Jane Michael. She's a nurse who recently retired from the University of Florida Department of Anesthesiology as the clinical research manager with a focus on blood management, research, patient outcomes, quality, and safety. Mary Jane, so good to see you.
You are muted.
You're muted, Mary Jane.
Great. There we go.
Yeah.
And greetings from wherever you may be. I'm so happy to be here with you today. Thank you.
Thank you so much. All right. So at this point, we're going to be inviting the conference chairman, Dr. Majid Rafai. He's a professor of pathology and laboratory medicine. He's from the University of Rochester Medical Center, Rochester, New York, in United States of America. He's going to be giving us his welcome address. Hello, Dr. Rajai.
Good morning, and thank you for the introduction. Good morning, everyone, or good afternoon or evening. Depends where you are, guys. It's morning for us here in USA. So it's my great pleasure and honor to welcome you all on behalf of the annual meeting organizing committee to the 2025 Bloodless Medicine and Surgery Society Conference. First of all, I would like to sincerely thank our sponsors, partners, and supporters who helped establish this meeting, and without it, this helping would be hard to establish a very successful meeting such like this one. I also want to recognize the hard work of our organizing team, who basically volunteers in this organization just to help establish such an successful annual meeting every year. Your speakers, thank you very much for being also volunteering to participate in this conference. And also I would like to thank our attendees who is making the time to attend this virtual meeting. Your presence demonstrates the significance of our conference. And our theme for this year is technology and bloodless medicine. So we're going to hear from physicians, researchers, supporters about the most recent technology that could be used to establish a bloodless, as much as possible, a bloodless medicine and surgery. Without further ado, I'm just want to welcome everyone again. And I would like to give the mic now to our president, Dr. Christopher Simotuo.
Thank you very much, Dr. Majid. Welcome to the 11th annual meeting of the Bloodless Medicine and Surgery Society. As always, it is going to be a rich academic feast of lectures and symposiums featuring some of the most brilliant clinicians and best scientific minds in the contemporary world. Bloodless Medicine and Surgery Society 2025 meeting is a multidisciplinary virtual meeting of the foremost medical professionals around the world who are dedicated to improving clinical outcomes, protecting patient rights, and bringing down healthcare costs through bloodless surgery, bloodless care. The theme for this year's meeting, technology and bloodless medicine, is very important because we live in a world in which a rapidly evolving technology has impacted virtually all facets of our lives, including healthcare. Technology in various forms has enhanced the practice of bloodless medicine, especially by minimizing blood loss, which is the second pillar of bloodless medicine. Bloodless medicine, on the other hand, has inspired innovation in medical technology. Both sides of this intriguing coin shall be discussed at this meeting by eminent medical scientists from around the world. We also expect a rich and diverse multidisciplinary international audience. Please take some time to go through the program and take note of the topics and the speakers. Plan to take part fully at this meeting. Ask questions. Share your thoughts, your ideas, your experiences. Take note of points from this meeting that you can use in your practice or that you can share with clinicians if you are an advocate of bloodless care. A big thank you to all the speakers, moderators, panelists, and all attendees. A big thank you to the organizing committee under the able leadership of Dr. Majed Rafai and the conference chair, who's the conference chair, and Adrian Kozniski, the conference secretary. Thank you all for joining us at BMSS 2025. Thank you.
And thank you, Dr. Sumito, for informing us today. And we have some very exciting sessions coming up and some seasoned speakers. And without mentioning their names, we have some oral abstract sessions today as well. But first, we have some housekeeping rules from Dr. Udak.
Thank you so much, Mary Jane. All right, so before we get started, first of all, let's have some housekeeping rules. Please let's remember that all questions should be placed. When we have the Q&A session, please get ready to ask your questions. Let's minimize the chats during the talks, and we don't want to distract everybody, okay? So please, while we're having our sessions, when the speakers are talking to us, let's try to take notes just like we were told. The program is also being streamed live on the BMSS YouTube channel, just in case you want to go on there. In case anyone has difficulty connecting to Zoom, you can just find the link in the chat box, please. Or you could just type Bloodless Medicine and Surgery Society on YouTube and you should get that. You'll be fine. All right. And please let's ensure that we keep our questions coming and we'll be excited to answer them as much as we can. All right. So over to you, Mary Jane.
Okay, this one should be an easy one for me. So the next speaker that I'd like to introduce is Dr. Bruce Spiess, and he is a retired associate chair for anesthesiology at the University of Florida School of Medicine in Gainesville, Florida. And he is a practicing cardiothoracic and liver transplant and trauma anesthesiology for 42 years. Dr. Spiess went to undergraduate school at Denison University and then medical school at Rush University and residency at Mayo Graduate School of Medicine. And then he practiced at Rush, University of Washington, and then at Virginia Commonwealth University. And that is where I met Dr. Spiess. Dr. Spiess took me under his wing and mentored me as well as all other students. And he became a very good friend of mine. And I think the thing that students loved him most was he always had an open door policy and was very easy to mentor students along the way. Dr. Spiess has traveled and lived around the world, and everybody knows him very well. He helped bring viscoelastic testing to the US for liver transplant and cardiac surgery, and he's published widely on TEG and coagulation. He's dedicated to patient blood management, and he's very charismatic if you ever talk to him about patient blood management. And he's also researched oxygen therapeutics in many forms. He has over 200 peer-reviewed publications to his credit and more than 50 book chapters and 7 textbooks, including perioperative transfusion medicine. And he's trained over 1,100 special forces combat medics in Operation Enduring Freedom. He considers himself semi-retired, but I hardly doubt that. And he seems to work a lot, if you ask me. He's in many professional organizations, and he did receive the Award of Excellence for Bloodless Medicine and Surgery. And I consider Dr. Spiess my true friend and mentor. And you can go ahead and carry it away, Dr. Spiess.
Thank you so much, Mary Jane. Man, I'm really touched by both being able to see you this morning and have you introduce me. That couldn't be any better as far as I'm concerned. And it's good to see you healthy, happy, big smile on your face. It just warms my heart. So I also want to thank Bloodless Medicine and Surgery Society for asking me to kick off this week's conference. I find myself here almost too often that I don't think you need to hear from me so much anymore as from many other people around the world. But it really is an honor to be here once again. It's something I look forward to every year, and particularly this year. I have to limit some of my comments because Mary Jane didn't mention I'm also the medical director, the chief medical officer for the company that makes one of the leading new technologies. So I'll try to give very balanced when I come to that point. So that's where I'm at. I'm a medical director of Hemosonics, but these are other things I've done and many more of which could be considered to be disclosures. All of us are very familiar with this urgent call to action to implement patient blood management. We've embraced it, I think, certainly from this society. And PBM has certainly evolved from AIDS avoidance all the way up to a whole healthcare total patient focus on quality nowadays. But I, in the last few years, and thankfully to this society, I've begun to focus my thinking that we're not there yet. Bloodless medicine and surgery needs to be our default. And I'll say that a couple more times as we go through this. And what I mean by that is that in patient blood management, the backup is always that you could go to a trigger to a transfusion if you needed to. And I think since transfusion doesn't have a solid outcome improvement basis with many randomized controlled trials, and we know a lot about the adverse outcomes, we should scientifically say that our goal is to not go to a trigger unless we absolutely have to. So our goal needs to be bloodless medicine and surgery. And as I said, PBM has not matured yet. It's fundamentally still backwards in that we are still looking at these triggers. And I want to make a couple of big points, and I'm gonna push them home here, which is that technology can only assist our goals. Technology is not the entire answer, and really mental or psychological approach to these problems is really our goal, and that requires teaching and requires education, and technology will only come out of and emerge out of a lot of creative thinking. And so the technology that I'm going to talk about here has not all emerged towards a goal of bloodless medicine and surgery, nor has it all evolved towards a outcome of PBM. It's evolved out of cost containment, AIDS reduction, efforts to reduce blood transfusion. But now I think we have a right and a push to push industry to say, focus on us, focus on PBM and BMS as a way for the future. And wouldn't I love to see one or two major corporations in the world decide that that's going to be their central focus? We're not there yet. So what we're not going to talk about is surgical technology to reduce bleeding, robots, blah, blah, blah. Those are things that have certainly contributed to us being able to do less bloody surgery. Pharmaceuticals, I'm not going to delve into all the pharmaceuticals that are out there. Those are technology. I'm not going to take up my cell phone and say, hey, what about this computer or AI? That's coming in the future. All of those pieces of technology are potentially future, nor am I going to talk about sealants, surgical surfaces, et cetera. But what I am going to talk about is what you might call thingamajigs, things that we can put our hands on. Many are electronic, some aren't. Some are very basic, very human oriented, very easy to use. So I'll say this again, technology can only help us to support and accomplish our vision, but our vision has to be in the forefront of everything we're forcing technology to do. Technology will not apply itself by itself. And I'll come to that when I talk about penetrance of certain technologies in certain systems. For example, cell salvage. Cell salvage has not penetrated the market as much as it should or it could be. Mary Jane and I know that. We fought against that. Viscoelastic testing is a very low penetrance for what it could do to help us all. So to support this society, we must embrace, educate, and continue to push those rocks uphill. And so reality is not what you see at first. Can you see the zebras in this picture? Mostly what you see are shadows. And I think for much of medicine for so long, many of the things that we've worshiped and a trigger, I've got perhaps the biggest paper I've ever written is about to come out in this next year, talking about hemoglobin and triggers for transfusion and how that's not right, and how that has just been a shadow and not the real truth. So let's dive into it. And I'm going to follow the three pillars because that's where the technology folds out to within the three pillars. And of course, all of us know these three pillars. We don't need to go and dive into what's in each one of them. But certainly in pillar one, in preoperative care, there is technology that should be utilized more, is capable of being utilized more. And Mary Jane and I came against a very hard brick wall when we tried to bring that technology to creating an anemia clinic at the University of Florida. And it's so damn simple, and it's so well supported, and technology exists, but what doesn't exist yet is the brain power and the philosophy to adopt the technology to accomplish what we all wish to accomplish. And that's anemia assessment. Anemia assessment needs to be another vital sign, and it needs to be in a vital sign that's done essentially at the bedside when the patient gets considered for surgery. And there are multiple ways to do it. Most of these technologies, which I'm showing you right here, they're very accurate, they're very quick, they need just a drop of blood, and they can be present in any surgeon's office. You don't even have to send the patient to a preoperative clinic. You could do it the minute you say, you know what, we're going to do surgery. Let's do surgery. And your surgery is a big enough anxiety for us that we might lose some blood. Let's find out if you're anemic or not. And let's get you corrected before you go for your elective procedures. So we need to screen everyone. And that needs to be a philosophy. That philosophy has not come yet to medicine. And the battle is still pushing the rocks uphill about how do you create an anemia clinic? Well, you wouldn't need to create an anemia clinic if it was in every medical practitioner's mind that we will not tolerate anemia and we will treat anemia. So why do we need to have these separate places to send people to make life more complicated when it should be just ingrained in all of our lives? But here's the one that Mary Jane and I tried to institute at University of Florida. And it's a pulse oximeter. Massimo, and by the way, these comments that I have, I'm not paid by anybody to make these comments. These are firm beliefs I have. And Massimo technology has a nice light emitting diode with multiple different wavelengths that can actually tell you an estimation of hemoglobin and such. And so we proposed at University of Florida in the preoperative clinic to say, let's use the Massimo technology to screen everybody who comes through for anemia. And what we were told was it's not accurate enough. Well, yes, it is. When you go to the literature, you find out that it is indeed highly accurate. The only place its accuracy falls apart, and yes, there's some bias. There's a slight bias of like a half or a quarter of a gram per deciliter of hemoglobin, but who the hell cares? on that when what you're trying to do is just screen, is this patient anemic or not? It doesn't fall apart in terms of its real true accuracy until you get to extremely low hemoglobins. And I would bet you that any technology has that a series of artifacts that fall apart at the far ends of either scale, either super low anemia or polycythemia. So I advocated for this at every surgical patient at University of Florida, but were blocked by the mental blocks. The mental blocks that say, this is a societal change, or you can't do this because what you're asking us to do is to change all of medicine. Yes, I am. Have I ever done that before? Yeah, that's been sort of my push all along. So why not in every surgical, as I said, and these are more data saying that the Massimo machine actually works. And is that a good enough correlation for you to say the correlation is there? And it doesn't cost, and here's the thing, it doesn't cost anything. Yeah, it costs an initial outlay, but these are reusable pulse oximeters. So it's not as though you have to pay for a disposable every time a patient comes to the unit. It can be done on every patient. And again, why is it not a vital sign? I went to my local practitioner this last week for a checkup on something. Yeah, I got my height, my weight, my blood pressure, but and a pulse oximetry. Why didn't they look at saying, hey, Dr. Spees, are you anemic? I happen to be polycythemic. I'm not anemic. So our second pillar has had some significant and major technologies that many of us actually use. And so the techniques and the ideas here, and our president and other people have already mentioned it, that in the second pillar, we want to salvage blood, we want to decrease bleeding by every way possible, and we want to assess hemostasis, coagulation, and be on top of that to assure that patients don't bleed unnecessarily. And so I'm going to spend a lot of my time here on the second pillar, and then and some of these that are used in the second pillar ought to be utilized in the third pillar, but they're not. And why are they not? Because the philosophy hasn't pushed us yet to say that technology is important in BMS, and the psychology and the view and the outlook has not yet embraced that every cell is important. Every red cell is important. Every platelet is important. Maybe every white cell is important too, but we focus on those and not wanting to just give activated white cells. But we certainly would like to not waste red cells, and we certainly would not like to waste everybody's platelets. But those seem to be vital things. So here's a technology that really is not available for all of you, but it's one that we used at Virginia Commonwealth University, and it opened my eyes in a huge way. And so this is made by Daxor, and it's a blood volume analysis using radioiodine labeled albumin that gets a very small number of microcuries gets injected, and that you can fairly quickly, within 20 minutes or half an hour or so, you can assess somebody's blood volume, and you can assess red cell volume utilizing this technology. Well, what opened my eyes when we did this study was how much red blood cells we lost. And you can't get into all of this data here in a big way, but what we found out was that our best estimations in the operating rooms, even when we were using cell salvage technology, this is for heart surgery, and yeah, we lose some blood in heart surgery, but even when we did all the things at the time that I thought we were doing pretty good medicine, we were still losing 40% more red cell mass than I had been able to account for. Wow. And I'll show you where it goes. And that brings to mind a take-home message for all of us that comes back to my initial message, which is we haven't matured yet. We haven't yet embraced the true vision that every darned red cell is vitally important. And so we had a loss of 40% of red cell mass that we couldn't account for. Not that everybody lost 40% of all their red cell mass, but just that 40% we couldn't account for. And look at the ICU. There's no recovery of red cell mass in the ICU. In other words, like for heart surgery, when we send people to the ICU, they get chest tubes. What happens to the chest tubes? It all gets thrown out. But here's what happens in the operating room. Here's what happens in the operating room. We've gotten better and better at being able to account for, actually measure how much blood is in those sponges, or how much blood is in those canisters, or in those Ratex that are hanging up. We've gotten better and better at that. But has anybody said, hey, that's not tolerable? Why are we sending that to the garbage? Why are we allowing blood to fall on the floor? Can't we build drapes over the patient that actually clear, suction, and move the red cells that are on the drapes into the cell salvage? That's really beyond 21st century technology. Suppose every drop of fluid that fell on the drape wasn't not just absorbed or not, but was actually scavenged. Can you do that? Yes, I think you can do that. So is it easier to just order blood from the blood bank than to develop a technology to harvest this? And I'll come back to that. I'm not going to go to that right away next, but it strikes me that we've spent a lot of time helping nursing and documentation to say how much blood loss is actually lost, but we've not taken the point to say, well, we're not going to tolerate that. Not that we're not going to tolerate the blood loss, because the blood loss has to happen, but all the blood in those sponges, what would happen if you could recover 95% of that? What would happen if you said, I don't care if you're having a tonsillectomy versus a cyst removal, we're just not going to tolerate any red cells that are yours escaping us into the garbage can. That's the kind of thinking we need. So cell salvage. We've come a long way in cell salvage. I started out my research career, or my career in anesthesia, long before cell salvage was even considered. I worked a bit with Haemonetics as they were designing early cell salvage machines. I did more with development of rapid infusion machines, but at the same time, in parallel, Haemonetics was starting, and other companies, Terumo and other companies, were starting to develop cell salvage machines. And this was around the time that, at the AIDS crisis, or just around the AIDS crisis, and it was done for the right reasons, to say, keep your own blood. But it was also done for the reasons to say, let's be cost effective. And today, that is still one of the biggest reasons why Mary Jane and I and others, when we've approached various surgical colleagues and said, hey, we think you could use cell salvage in this situation, they've said, it's not as cost effective as me just ordering a unit of blood. So, well, now wait a minute. Is that good medicine? We all here know that's not necessarily good medicine. So there's many different manufacturers and machines. This has ballooned into an industry. It's a dramatic big industry, and it's a huge step forward. And I'm not going to compare each one of these to the other ones to try to tell you which one is either the best, or is the least costly, or is the best for your situation at your hospital. But here's what I can tell you is every hospital that uses cell salvage chooses a cell salvage machine based upon an overall bundled contract for that hospital. In other words, it's if we have the blood bank using a technology where a cell salvage company also makes a cell salvage machine, or we have a cardiopulmonary bypass company that's supplying the cardiopulmonary bypass, then maybe the cell salvage machines get thrown into those. And so it's not always, and nor should it be, the decision of every surgeon that, hey, I like this manufacturer and I don't like that manufacturer. But they're out there, and there's a lot of them. And I probably don't even have half of the manufacturers photographed here. And yes, they all have slight differences of how fast they cycle, how much suction you can use, what their filtration is like. But I will talk about the ICEP somewhat separately, because I think that one is a next step forward for us coming out of France. But there's a lot of myths about cell salvage, and I would recommend to anybody, those of you who are into cell salvage, know both Jonathan Waters, probably our world's expert on cell salvage. He's now semi-retired. Unlike me, he's decided that he's going to go get a PhD. I can't imagine being semi-retired and saying, I'm just going to go get a PhD in history now. So he's now in Oxford in England getting a PhD in history and really focusing on history of medicine and transfusion. But so also is Jonathan Yar, another big name. But read Margit Kaufman's summary on this. It's probably the best one that's out there. And these are myths about cell salvage, and they're realities. And there are lots of myths, and they're just like the myths that we all get when it comes to patient blood management or BMS, is that we get these myths thrown in our face all the time. But when you wish to debate somebody about cell salvage, go and get the data. Go and get the data and be ready to refute it, to say, no, wait a minute, that's not really true. It is actually more cost effective than just letting patients bleed and getting units of blood from the blood bank. Because the cost of a unit of blood from the blood bank is not just what it costs Dr. Rafai to go and buy it at the local supplier. It's everything in the hospitalization plus the adverse event costs. And the adverse event costs are not very often thrown into those cost analyses. But so everybody knows this, it's collecting the blood at the surgical site, anticoagulating it, and then running it through this centrifugal washing machine and washing it correctly. So there are lots of randomized controlled trials, and some of these are well analyzed in this summary article. But here on the right, I want you to take a look. And when I said that we've got a long ways to go in total hip surgery, only 10.6% of surgeons or surgeries for total hip are using cell salvage. Really? Only around 10%, and that's the big one. For cardiac surgery, it's still under 10% for valve surgery, 2.5% for CABG surgery. Wow, why? And this is one where Mary Jane and I ran up against, which was for spine surgery, to say to our spine surgeons, why aren't you using cell salvage? And it brings up the question, we have the MESBOS, or surgical blood ordering system, or minimal surgical or maximal surgical blood ordering suggested listing. Why don't we have technologies that hospitals say, if you're going to do this surgery, we want you to use this technology? But here's also, I've heard many, many things about the quality of the red cells we get back from cell salvage. And the honest to goodness truth is, if you read all of this, the quality is still the best that you can get. It's the freshest, warmest, best red cells. Yeah, there are some dysfunctions. Yeah, there are some cytokines made. Yeah, there's some fat, there's some fatty and lipid metabolites that get in there, but they're far less than the alternatives. So cell salvage still is the best of the best. Yes, you can have contamination. Yes, you could have, for example, in obstetrics, and there's a lot of anxiety and so the anxiety in many of these subspecialties has outweighed the scientific literature. And people have weighed in to follow anxiety, not science. And particularly, I'm going to focus next on one that has to do, or shortly, I'll focus on one that has to do with cancer, because I think we're about to solve that problem. And I understand it that we would very often have the anxiety of saying, well, if I'm going to have a major abdominal cancer surgery, like a bowel resection for colon cancer, do I want to suck up all those cancer cells and have them then reinfused? Even even though the literature cannot show an increase in metastases, I get it that mentally is an anxiety that some people have troubles living with. And then there's the costs. So here are the costs, and as I say, when you come down to what's the real actual total hospital loaded cost of a unit of blood, these are coming into being pretty damn cost effective. So what's the cost effective in contextual context? In spine fusion for multiple levels is extremely cost effective. In pelvic trauma, and you can see, and they're all in this article for you to be able to be armed with to say, yeah, it is cost effective. And in many places, it's extremely cost effective. But the default is still, well, if we only lose 600 to 1,000 cc's of blood for this surgery, maybe I don't need Cell Saver and I shouldn't spend that $600 to set it on up. Well, the problem with that is, again, that the mental attitude is, if I need something, I'll default and go to the blood bank. Instead of the mental attitude is, your red cells matter. And your blood is your blood, and it should stay in you no matter what. And then I'll worry about quote unquote cost effectiveness. It's short-sightedness, cutting off our nose to spite our face. So the conclusion is the cell salvage is cost-effective intervention, particularly when employed selectively in high-risk cases. Well, what's the definition of high-risk cases? This, again, is our own self stubbing our foot against, something that we shouldn't stub our feet on. Is that I don't say that cell salvage should be utilized, excuse me, in every last case that ever comes into the operating room. That's way over. But when we only get 10% penetrance for cases that we know are going to bleed, we got a problem. So cancer surgery, sorry for my coffee this morning, but so our cancer surgery has been a chronic excuse for not using cell salvage. But now we are on the verge, or we have in existence for us a chance to take a giant leap forward. And we do know that if you are transfused with allogeneic blood during either kidney, prostate, or colon cancer, your metastatic rates go up, and you don't live as long, and you don't do as well, and it's probably due to the immunosuppression that Neil Blumberg and others talk about. Well, there's a company that I've been working with out of Germany called Lindus Blood Care, and they have developed a series of monoclonal antibodies to EpCAM1, which is an antigen present on most tumor cells and epithelial cell adhesion molecules. And that particular antibody can be put into the cell salvage reservoir. And in that reservoir, then this particular antibody, what's called Cativab, can bind cancer cells one to another, and they agglutinate. And you make these large agglutinations of cancer cells that precipitate and can be easily easily removed by the by the centrifugal force of the machine. And I've got a couple of these slides that are probably too many for these slides, but the antibody induces that aggregation between the cells. And what they have shown in their largest study to date is essentially taking as many as 1 million or more cancer cells and bringing it down to negligible, or at the most 4 cancer cells able to be found at all. And that is going through European approval right now. It should and hopefully will be approved for sale in Europe within the next 6 months, or within maybe even the next month or two before the first of the year. And I'm assisting the company to help them go through the US FDA. And I think that alone would make a huge difference to relieve anxiety in surgeons. And wouldn't you like it if you were a patient to say, hey, we're going to use this new technology for you. We're going to salvage your own blood and make sure you get your own blood back and remove any cancer cells out of it. It does also open the idea that if you use this technology in line with other filtering systems, could you create a way to filter cancer cells out of spontaneously perfusing patients at specific times? And they are working on other antibodies as well. So here's the Catavab efficacy. Extremely efficacious. I want to get beyond that because otherwise I could spend the whole time just getting down into the weeds on that. My problems with cell salvage, it's slated for high-risk bleeding only. Well, now wait a minute. What's moderate risk bleeding? What's even a little risk bleeding that goes sideways and becomes high-risk bleeding? Why don't we take the view that we're going to set up a sterile cell salvage technology in every patient and run the blood only when we get enough blood? Or why don't we actually develop the technologies to be smaller centrifugal bowls? We had that when it was being used in the ICU, and then nobody used it. And so it got dropped off the market. And the reason it got dropped off the market is because it didn't sell. Well, why didn't it sell? Because we don't have the psychology and the embracement that every one of my red cells is important. So small bowl size has been able to be done, and it should be able to be done for pediatrics. Well, why shouldn't you do that for any other case? That if I can get 150 cc's of my own red blood cells back, well, then maybe we can talk about what's cost effective there. But maybe there are ways to make things more cost effective. And things become more cost effective if medicine demands it and medicine utilizes it routinely. Now, here's an extremely cost-effective technology that I've been involved with that I wish all of us would use more and more. Mary Jane knows it. She and I worked with Hemoclear company out of the Netherlands that has developed this incredibly unique, cool stack of filters. It's 37 filters that are, okay, we're supposed to filter blood every time we transfuse it to remove big particles and agglutinated red cells and other debris, et cetera. But suppose you change the stacking of the filters such that you keep all the good and normal red cells on one side and many of the platelets, and you dilute the garbage out through the other side. And so they've created this really unique filter that you can see it. Well, the filter sits on an IV pole, and it has to be slanted at an angle so that the blood runs into the filter, mixes with the diluent, and then out of the bottom of the filter comes 2 sides. One side has normal red cells and platelets at about a 50% hematocrit or so, and out the other side comes plasma and essentially what I'll call garbage or waste product. So how does it compare? It compares really well. It compares really well with cell saver washing. And especially if you wash it twice. So you hang your bag of red cells or what you collected in a canister, run it through with saline. But what's really cool, if you look down on the lower left-hand side there, is you get red blood cells and you get platelets. And most of these cell salvage machines, you lose all your platelets. But if I'm getting my own white blood cells, red blood cells, and and such back, and I get my platelets back, that to me is an advantage. And this is low-cost technology. This technology costs far less than $100 a filter, and it's all just manual. Just hang a bag of saline, hang your collected blood up there, let it run through. Yeah, it takes 15 or 20 minutes, but how much time total does it take to run two runs through the filter? It takes less than 20 minutes. What does cell salvage take? I don't know. It depends on where you want to say you started processing. It's certainly a period of time, and it's certainly more than 10 minutes to get a bag back. So, and it costs a lot more money and stuff. So it's actually being trialed for C-sections in South Africa, and very many physicians won't use cell salvage in C-sections because they're worried about placental and amniotic fluid and such getting on in there and other debris. But here it is in South Africa being utilized. And I know in Kenya and Nigeria, some places are using it. There's talk about military being able to use it. In austere environments, in combat, this would be fantastic. I think it would salvage a lot of blood that would otherwise go unutilized. And I think in the ICU, and I tried to suggest this before I left practice, was to say, well, now wait a minute. If we took the chest tube drainage and we ran it through here, couldn't we do this in a low-tech way and salvage everybody's red cells? So that to me comes to the innovation. If we just innovate, what can we do? The technology's there. It's not terribly costly. It just means that somebody has to innovate. And unfortunately, most of the chest tube drainage and other drainages for things like hip surgery and stuff don't have readily available ways to sterilely take the blood out. It's because the focus has been, this is a waste product. It's not the focus has been by technology companies that this is a valuable resource. This is a valuable resource. We need to demand it. And here's the valuable resource that we throw away. Well, why do we tolerate that? Because we do. Because nobody said we can't tolerate that. There's a company, Gauss Medical, that makes a really nice high-tech computerized technology that you can hold up your laptop computer in front of it and it shines different wavelengths of light at either a canister or actually at a Raytec or a lap sponge and tells you exactly how much red cell concentration is in that. But what's that about? That's about making an accurate estimation of blood loss so that we can put it on a medical record. It's not about salvaging the blood, and it's not, and it has been focused upon, let's give you an accurate number so you know when to call up Dr. Rafai and say, hey, I need 3 units of red blood cells. It's not about, hey, how can I salvage that? Well, suppose you put that technology to work with this. This is the ProCell sponge washing and blood recovery system. And it's low tech again. You throw your sponges in there, you put some saline in there, It's almost like a salad spinner or a squisher that squishes out the red blood cells. And the nurses can have it right on their back table. Tried to propose this at University of Florida. Nah, we don't want to do that. Nah, that would take up the nurse's time. Nah, we're fine the way we are. The worst line you can say is we're doing just fine the way we are. That to me is a blockade for so much that can happen in the future. And when you look at the ProCell, it performs very, very effectively. It can recover like 85, 89% of red cells that are in those sponges. Well, okay, suppose we automated that. Suppose we fully automated that and put it in conjunction with the Gauss medical system, and you could and you could also count the sponges at the same time. You could make a washing machine that does all of this, but so far nobody's demanded it because we mentally haven't come to that. Okay, let me take the last 5 minutes or so, because I'm probably about to run over my time, but talk about viscoelastic testing. I have to be careful here because I am the medical director of one of these companies. But let me just say, and I'm going to try to be as even-handed as I can, that there are 3 systems now that have come out since 2019 that are bedside point of care, near real-time coagulation analyzing systems that will tell you in a minimum of 6 to 8 minutes and a maximum of about 25 minutes what's wrong with your patient's blood and what you might need to do to correct that. That to me is a quantum leap ahead. And when we used to have to send blood to what I call CLCA, which is central laboratory coagulation analysis. That's a term that I've coined because when we send to a central lab, we are inhibited by time situations right off the bat. Drawing a lab in an operating room or in an obstetrical suite or in a trauma suite and having to put it in a vacutainer and send it to a central lab means right off the bat, we're probably losing 20 minutes to half an hour just from transport time, clerical time, before they even put it on the machine to tell you, okay, so if you get a real fast PT and PTT or fast fibrinogen, at best, you're probably going to be looking at an hour to get your things back. Viscoelastic testing looks at the entire interaction of all these systems all happening at once. And for me, I like the big concept. If you think about that CLCA or central laboratory testing where you're breaking things down into the subgroups, might be looking at individual trees where there's a VET, looks at everything interacting together. It's the ecosystem. How's the ecosystem performing? And then through the ecosystem, can we then, with various activators and inhibitors, ferret out some abnormalities that we wouldn't otherwise be able to ferret out? So it looks at whole blood clot strength over time. Well, clot strength is viscosity and elasticity, and that's stress versus strain. I'm not going to have the time to go into the physics of all of it, but each one of the technologies uses a different system and mechanism for looking at stress and strain of the clot as it forms. The one I work with uses ultrasound. The other systems use either a pin and cup, or now the latest TEG measurement uses how vibration is propagated across the surface or the meniscus of a drop of blood, just the way you might look at propagation of vibration when you throw a stone into a pond and you look at the vibrations going across the pond. But here's the point. The Cochrane Library has done a number of reviews on viscoelastic testing in general, and has shown it to be extremely useful in reducing blood utilization and improving patient outcomes. But those analyses were done long before it was ever available as a point-of-care test. Now it's available as a point-of-care test. And even with it as a non-point of care test, and even with the Cochrane collaboratives, less than 20% of hospitals in the United States have adopted the technology. Now we need to insist that 100% of hospitals doing major surgery with potential blood loss and coagulopathy and obstetrics and stuff have this technology available. What would you want if it was you? Wouldn't you want to know whether you're likely to bleed or not? So back in the mid 1980s, early 1980s, I published one of the first articles showing that TEG at that time, SCT stands for sonoclot, RCT stands for routine coagulation testing from the labs, the CLCA, was accurate, 88% accurate in predicting who was going to bleed in heart surgery. I went to the NIH and said, hey, I bet I can reduce bleeding in heart surgery. And they told me to lose their address because everybody knew that TEG was a worthless test, and that my attempt to get money to try to reduce bleeding in heart surgery, that everybody knew you had to transfuse people in heart surgery. So now today, and I'm gonna skip to the ends of this. Now today, in this last year, there were 877 articles published in the world's literature regarding viscoelastic testing. So do I feel vindicated? A slight bit vindicated, yes. But viscoelastic testing tells us, does the clot start on time? Does the clot grow and proceed normally? Does it achieve normal strength? And does it hang together or does it break down? Well, if you know all those things, I suggest to you that patients are less likely to bleed. And more analyses just supporting the same thing, saying that not only does it have positive predictive value, but it has profound negative predictive value. In other words, if the viscoelastic testing shows that the clotting is normal, with greater than 90% accuracy, I can look a surgeon in the eye and say, something's bleeding and you haven't found it. And it needs some factor 6, that's 6-O-proline. You need to go in, you need to clot that sucker off and tie it down. So real-time individual coagulation management can be a huge giant leap forward. Well, how can that be for bloodless medicine and surgery? Well, if you can anticipate when your patient's getting close to being a problem, you might be able to do something about it. We now have fibrinogen concentrates, prothrombin concentrates, 4-component PCCs, and TXA, Amicar, and DDAVP. Can we use all of those instead of robbing the blood bank, going to Refi and saying, hey, I need 3 rounds of cryo, send me as much FFP as you can, can we get ahead of the situation? And could we, if we knew that, hey, my patient has roughly 50,000 platelets, can I up the fibrinogen concentration and make that clot stronger and make everything work better? And the answer to that is future for research. But the new technologies we need to have, and these are ones that I think need to be developed. These are ones that I actually have, some of these I have drawings for what to do, and they're in my possession. Autologous ANH, we need an automated system. Why is ANH not functional? Because it's a cottage industry and every anesthesiologist does it differently. And every anesthesiologist doesn't do it to its maximum effect. Suppose we had a machine that did a push and pull and took 100 cc's out and gave 100 cc's of fluid back, and you hit a target hemoglobin hematocrit before your surgery, and you could have 3 to 4 units of fresh, warm, whole blood right on the back table if your patient starts to bleed and not be losing those red cells. Wouldn't it be something? Suppose we automated the ProCell and developed it into something really tremendous. Suppose we took the HemoClear device and added things to it. Suppose we created surgical drapes that collect and funnel and salvage blood actually in real time without anybody lifting a finger. Wouldn't that be something? And suppose in the ICU we didn't tolerate that drains with blood were just thrown out. So in conclusion, we must embrace bloodless medicine and surgery. We have to embrace it. We have to make the mental change to saying that blood is an organ. Blood is my organ. You can't throw it away just because it's simpler and easier for you to pick up the phone and give me somebody else's dysfunctional organ. Give me what I have, and it's laying there right in front of you. But the lay public needs to be educated. The lay public, when we made the giant leap forward, it was because of AIDS, and it was because they were outraged. And so the lay public needs to be. BMS will always be cheaper than transfusion and standard care if you look in adverse events and you get them modeled in. So we need a company or multiple companies to embrace and say, we're here to make the technology that you guys need and demand, but it won't happen if we don't demand it. And I'll stop there and get off my high horse and quit preaching to this wonderful choir, because you guys are the choir, and you sing the same song I do. And I think I'll stop there. I'll probably go in a couple minutes over, and for that, I apologize, but thank you very much for your attention. Thanks, Mary Jane, and everybody, for your wonderful attention. There probably, all of you know other technologies, things I haven't hit on. Think about them, and think about, are we using them correctly to their maximum? Thank you.
Thank you so much, Dr. Spears, for that exhaustive session. That was beautiful. Thank you so much. So right now we're going to be moving on to the 7th BMSS Arashanda lecture. That for today is going to be taken by Dr. Valivan Jivanandam, and the theme is Bloodless Cardiac Transplant, the Stuff of Legends. So for the 7th, for our BMSS Arashanda lecture, this is actually the 7th edition. We've been having this as a key feature of the BMSS annual meeting since 2019. And the first lecture was delivered by Dr. Arashanda himself. He's a retired, world-renowned cardiac anesthesiologist and an award-winning member of the BMSS. He's also a foremost contemporary bloodless medicine practitioner. And the aim of this lecture really is to encourage the promotion and science and practice of bloodless medicine and surgery, mostly for the improvement of clinical outcomes and the protection of the rights of our patients. And how do we take a peek of who is going to take the lecture? Usually a person who has a track record of outstanding academic and or clinical work in bloodless medicine and surgery. And for today, the honor has been bestowed on Dr. Valivan Jivanandam. He is a doctor that specializes in the surgical management of heart failure and is an expert in high-risk cardiac surgery. He has performed over 1,500 heart transplants and has a special interest in treating patients traditionally considered inoperable. He has reconstructed damaged hearts in many patients awaiting transplant, enabling them to forego transplantation. He also has successfully performed transplants involving patients who do not fit the standard criteria. Additionally, he has received a national attention for his skill in performing bloodless complex cardiac surgeries, which require the use of precise surgical techniques to minimize blood loss during the procedure, hence sparing the need for blood transfusion. He is, of course, a pioneer in the field of mechanical circulatory support, and throughout his career has performed first in human device implants and nearly 500 durable left ventricular assist device surgeries. So Dr. Jivanandam was one of the physician leaders of the transplant care team that made history in December 2018 after performing 2 triple organ transplants within 27 hours, replacing failing hearts, livers, and kidneys of 2 29-year-old patients. He has performed the heart transplantation operation for all 13 heart, liver, and kidney transplants at the University of Chicago. The heart transplant program, using data from the latest reports from the US Department of Health and Human Services, is the best in the United States of America with regard to patient survival and the shortest wait list times. In addition, the UCM program is the only program offering and performing heart transplants and LVADs for patients declining blood transfusions. We're happy to have you here, Dr. Jivanandam. Over to you. Thank you for joining us.
Thank you very much. It's an honor to be here, and I will now share my screen. Great. So I'm going to talk today about heart transplantation, and I don't know about the stuff of legends, but that was a title that was given to me. So I have no disclosures. I will say that I'm a pretty obsessive compulsive over-engineer, and I chose kind of this field of bloodless medicine because it was a challenge, and it's a place where I could make a difference. Because if you're taking routine cases, it's very difficult to show the difference of over-engineering. But I think when you talk about bloodless medicine, we can see the difference. And so I got interested in these challenges. We define patients as PDRB. These are people who refuse blood products, even if it leads to death. We say they definitively refuse blood products. And in general, there are Jehovah's Witness population. The good news is that we've taken the lessons we've learned, and it really drives our blood management program, patient blood management program, and that's completely driven by our bloodless experience. So transplantation is a little bit different than just normal cardiac surgery because it involves a very, very large team of people that have to get together and work together to make this work. So this team, before we start doing bloodless transplant, you have to make sure that the team is psychologically stable and physiologically aligned to be able to offer this care, because not everybody has the same beliefs. And so although they don't have the same beliefs, they need to be able to respect everybody's beliefs. And, mortalities will occur due to bloodless therapy. And is the team ready to handle this? Because, the team does have to report to organizations like the SRTR, the STS, US News and World, and there are no risk factors for doing bloodless surgery. So the institution of the program is taking additional risk. And so you need to have institutional acceptance. And remember, hearts are a very, very valuable societal resource, and we are stewards of that resource, and we have to use it in patients who can benefit the most. Why do we do this? We are providing access to an underserved population of patients, and by learning on how to do these procedures, we are decreasing blood utilization across all patients. So how do we do this? Transfusions are a critical safety net. They're administered in 20 to 50% to 60% of cardiac surgery and about 50% of heart transplants. So the real key thing here is that the treatment of bleeding is usually not successful, because once somebody starts bleeding, it's too late. And so prevention is the secret. And prevention is attained by being selective, preoperative preparation, and surgical techniques. Of course, postoperative management is critical as well, and we'll go into that subsequently. So we do have selection challenges, and the things, if you have a virgin chest non-reop, it's a pretty straightforward transplant, but how do you take it to the next level? So we talk about reoperation sternotomies. A third of our patients are reoperations, and they come to us with complex chest anatomy. This is a patient from Colorado. He's a male. He's had a coarct repair and an aortic valve repair at infancy. He then developed a type B dissection with a carotid, the subclavian bypass. And as you can see here, he has a stent across his descending aorta, across his arch. He then developed aortic insufficiency and received an aortic valve and Bentall. And now he's presenting for a heart transplant because he has a cardiomyopathy. So going into a patient like this requires a little bit of courage for the entire team, because now it's a fourth time re-op sternotomy in a patient whose arch is restricted because of a graft, whose innominate artery is very close to the sternum, and whose sternum is, because of a lot of his sternotomies, is malpositioned. But these are the type of patients we do, and he did get his transplant about 6 months ago and is doing great. Other challenges are patients with radiation, or people who have had an LVAD in the past where you now want to take an LVAD out and transplant them, and patients with complex congenital problems, specifically Fontans with single ventricles, although we've now done a patient as well with complex Fontan reconstruction. You have to look at their percent reactive antibodies. The good news is that if they've not accepted blood in the past, usually their PRAs are not an issue, but of course they're an issue for females who have had multiple children. Hepatic function is very important, because if these people need a liver transplant, a heart liver transplant bloodlessly is, I don't think, possible. You have to look at their renal function. Some of these patients are possible heart kidney transplants. And then you have to look at their bridging strategies, right? So durable LVADs for Jehovah's Witness patients is probably not a great bridging strategy, because taking one out bloodlessly is a real challenge and probably not possible consistently. It can be done, but maybe not consistently. ECMO, we've used ECMO as a bridge in select patients. We've used the balloon pump, is probably the least destructive for blood. So we've used the balloon pump the most for bridging patients. And of course, the newer Impella 5.5, we've used those for bridging patients as well. So I said that this is a stepwise procedure in terms of prevention. So of course, selection and preoperative preparation are important. So before the operation, you need to stop anything that can cause bleeding, such as Coumadin, Plavix, aspirin, fish oil. Now, having said all that, we find that Coumadin actually is not a bad way to bridge people to transplant, because for a transplant, we usually have about 36 hours of advance notice, at which time we will stop their Coumadin and we'll give them vitamin K. We give them IV vitamin K, 10 milligrams, and we do that every 4 hours. We don't even check their PT anymore, because we know it probably reverses within about 6 to 8 hours. And we just continue giving it every 4 hours till their surgery. Plavix is a problem that needs to be stopped. Aspirin, baby aspirin, we can operate with baby aspirin, and all their supplements can be stopped. We like to build up their hemoglobin before any type of transplant. If they're in the hospital, we can give them 20,000 units sub-Q every day. We also give it to them immediately intraoperatively. And there are several studies that show that Epigen can decrease AKI, transfusions, and inflammation if given immediately pre-op. So in the operating room on induction for all our bloodless patients, we give them 20,000 units of Epigen. We follow their ferritin levels and give them iron as needed. And we replenish their B vitamins. This is also very important. For patients who are awaiting transplant, the default is to quote unquote optimize them by drying them up. We actually have our cardiologists hold these diuretics. These patients will never be fully optimized. They'll come to the operating room with a lot of blood volume, but that helps us during our surgery if we want to do them bloodlessly. So then, you come to the operation, and as Bruce Spiess said, you want to keep everything inside the patient. The better you keep it inside the patient, the blood loss that you're going to have. So, we always talk about meticulous surgical technique. I give this lecture many places, and I don't think there's a surgeon I've ever met who doesn't say he's the most meticulous person in the world. But we have a very limited team. These operations do take a longer period of time. We often don't like to do 2 cases in a room in the same day, because drying up these patients can take hours, because we don't send them to the ICU until they're bone dry. You have to be self-critical and honest. If there's something bleeding, you can't assume that it will eventually stop. You have to go after that bleeding. And as Dr. Space said, he says he uses factor 6, which is 6-proline. Well, as a surgeon, we can use 3-0, 4-0, 5-0, 6-0, 7-0 to fix these bleedings. So the most common cause of bleeding is the sternum. So we are very meticulous about our sternal preparation. We will go on the periosteum, and we don't use wax, we use hemosorb, which is something that is absorbable, so it doesn't stick around. But the key here is that we do the sternum 3 times before we actually put a retractor in. We put a retractor in with some new knit gauze and some towels, and this tamponades the bleeding off the sternum, so we don't have bleeding to deal with. You can see how dry that surgical field is. After we're done, we actually oppose our sternum with plates. You can see the plates here. These are titanium plates that are designed by several companies now. And what we have shown is that they decrease bleeding because there's less microabrasion of the sternum, micro movements that can cause bleeding. And so we use these plates routinely. When we actually do operate, every single thing we have to be careful about: mediastinal fat, pericardial edges, adhesions. Every small bleeder adds up. We do our entire dissection with electrocautery, either with monopolar or bipolar coagulation scissors. You can see there we're using this scissor. Now, it's very, very tempting to take a finger and do blunt dissection here, but we absolutely will not do blunt dissection, because blunt dissection will lead to bleeding from the pericardial surfaces. You can see here that even deep down in the chest wall, we will use those scissors, and this is us using our monopolars. And again, very, very tempting to do this with your finger, but you will pay the price later. In patients who do have some inflammatory adhesions, we use this device called the Aquamantis. The Aquamantis is great in terms of taking raw surfaces and decreasing bleeding. Of course, the other thing is suture deficiency. We do a lot of suturing in cardiac surgery. What I do is, if there are any inaccessible sites, we will do double rows, or we will suture one direction, stop, go back, and then suture back. So it's protection for all these sites even before they stop bleeding. Because the most important thing that we have to do is you have to predict these problems. And you need to predict the problems and go after difficult sites. So I'm going to show you a heart transplant. This is a heart transplant talk. You can see here the pericardium being open. You can see how large and dysfunctional this heart is. We will go on cardiopulmonary bypass with the heart, and then we will go ahead and apply our aortic cross clamp right there. We open up the SVC. It's this area right here. You'll see this is an electrode that's inside. And we cut out all their pacemakers and ICDs because with their new heart, they don't need them anymore. This is cutting through the aorta. And adjacent to it will be our pulmonary artery there. So this is the aorta, that's the pulmonary artery. You've seen us divide the SVC. And what we're doing now is, before we take the heart out, we will take out the posterior wall of the left atrium and the IVC, and here the heart will come out. You can see how large and boggy this heart is when it comes out. The most important thing that we're not showing here is that we then reverse the heart and then make sure we take all the blood from the heart. And this is the heart, the chest, ready for a transplant. This is the left pulmonary vein, that's the right pulmonary vein, and this is the IVC, SVC, aorta, and PA. So the heart does come to us in an ice jar. Those are some of the nodes that come with the patient. And here's the heart that comes up. By regulations, we have to label it as a heart. So we don't get a liver transported for a heart transplant. We take the heart out of the bucket, and you can see how much smaller this heart is going to be than the heart that came out. Then we go ahead and prepare this heart for transplant on the back table. We separate out the aorta and PA and make everything ready for our connections. That's the pulmonary venous connections, getting ready for anastomosis. That's your inferior vena cava anastomosis there. And then we start the process of sewing this in. The first anastomosis is the left superior pulmonary vein. This is called a total technique. You could also do this technique a little bit easier by doing the left atrium as one anastomosis. You can see we do this anastomosis first because it's very, very inaccessible and it's all the way in the posterior aspect of the heart. Then we flip the heart around and do the right superior pulmonary vein, which is what we're doing here. And again, if we put a stitch in and it's not perfect, we go backwards and then we go forwards again. This is our SVC anastomosis now being performed. You can see that's a Swan-Ganz catheter. The SVC is done. That's now the pulmonary artery anastomosis. And now we're going to put the aortic anastomosis together. And so this is what this looks like. Now it's all replaced. And then we start feeding the heart blood. We've got to wake the heart up. So we do a little coochie-coochie action, tickle the heart to start working. The heart slowly starts beating. And then within a couple of minutes, you'll see it becomes a lot more rigorous. And then we go ahead and take out the cannulas. And you can see now this heart is completely working on its own. You can see how much more vigorous it is than the heart that came out. So you need to be able to predict the problems. And that, again, is self-reflection about how difficult something is to fix and what is the frequency of this problem. I've identified in transplant, anything on this side we can see and fix easily. Anything on this side is underneath the sternum. It's away from the surgeon. It's hard to fix. And so this is the aortic cannulation site. This is the pulmonary artery, and this is the pulmonary vein. And so what we do for the aortic cannulation site, which can ooze, and we can salvage this blood, but as Dr. Spies says, why lose blood from the circulation when you can keep it inside the circulation? So we're pretty meticulous about putting in pledgeted sutures for our cannulation. You can see our cannulation being done there, and there's no blood outside the cannulation. This is another one of this preventive things. This is at the left atrial anastomosis, and we go ahead and put some pledgeted sutures in here before it starts bleeding. So it doesn't even have a chance to bleed. So we don't have to deal with this after surgery. And for our pulmonary artery, what we do is, there we go. We actually fold the pulmonary artery back on itself and give it extra tissue to do this anastomosis, because we know that the posterior aspect of the PA can bleed. So this becomes a 3-layer as opposed to a 2-layer anastomosis. And that, of course, allows us to prevent bleeding there. So the other thing we talked about that Dr. Spies talked about was sponges and pads. And I completely agree with him, except we take a totally different approach, right? Because what we do is we started off with sponges and pads. Then we used to wring them out. Then we used the ProCell. But then I came to the realization that if the surgeon could just put his mind in terms of reusing sponges and pads, we didn't have to use any sponges and pads. And so our entire operation, whether it's a transplant or an LVAD, is just done with one 4x4 and one lap pad. And we just reuse the same ones over and over again. So, this is our ProCell technique that's done at the back table. We just have our nurses wring it out, and then we'll suck it back into Cell Saver. But at the end, that's it. That is after a heart transplant. We use one lap, one 4x4. Yes, it is work. You're not getting fresh white gauze to use, but the nurses don't have to count. There's no counts involved because there's only one 4x4 and one lap. And that obviously saves a lot of blood loss. Everything else either is salvaged by the pump. We like to salvage everything by pump. Matter of fact, we minimize Cell Saver as well, and we try to do everything back to the pump. We warm these patients. You have to warm them and keep them warm consistently. So we warm them for 37 degrees for at least 10 minutes before we come off bypass. Then there are other things that we do, and this is synchronization. It's like an orchestra between the surgeon, anesthesiologist, and perfusion. So we know that you take a hematocrit measurement at baseline, and just before heparin, we lose about 4 to 5 percentage points of hematocrit. That's usually anesthesia volume that's given during induction. But look at between perfusion and surgery, we only lose about 3 hematocrit points. And that's because of everything that we keep and save in the circuit. We actually have multiple circuits. So we don't use one circuit, doesn't fit all. We had circuits that started at a 2-liter prime, but now we have 4 circuits depending on BSA. We have our small circuit, which is all 3/8-inch tubing. That's only 850 cc's of prime as opposed to 2 liters. We have other specialized circuits that are a little bit more prime, but are for bigger patients. Our pediatric circuit, we use that for very small patients at 700 cc's. We do retrograde autologous priming, and we replace our cardiopecia prime that saves more volume. And the other thing that we do is our perfusion is run with a very, very low venous reservoir. So the minimum alarm we can set is like 100, 200 cc's. Normally it's 400, 500 cc's. So anybody who comes into the operating room and watches us operate, you think you think instead of music, we have like alarms going off. That's our music, because we always run very, very low venous reservoir numbers. The other thing that I think is probably one of the most important things we do is draining of patients just before bypass. This allows us to save warm, fresh blood, and it preserves all their platelets and coagulation proteins. We do this in a very controlled manner. We usually get about 600 to 1.2 liters. If you have a large man, the other day I did a 400-pound Jehovah's Witness bloodless LVAD implant, and we were able to get 2 liters off of him because he was so volume overloaded. Now, taking this blood, you really need to be in control of the blood pressure. And so we control that blood pressure by position and anesthesia level. Again, you have to depend on your anesthesiologist to make all this work. Now, this blood is magic, and it is golden, and we reinfuse it after a bypass run, after protamine, and when we see that there's no surgical bleeding. So this is to reverse the coagulopathy. And we now use this in all our patients, whether they are bloodless patients or not. And we basically almost eliminated our need for postoperative FFP and cryo, and we don't even do viscoelastic testing anymore because our patients just don't bleed. So this is how we do our autologous blood conservation. The first thing we do when we're ready to make skin incision is to put the patient in a head-up position. And you will see that here. You can see the table being moved into the head-up position as much as tolerated. The reason for this is that when we do our sternotomy and we do our cannulation, we decrease the amount of blood in the chest, so it decreases blood loss. You can see in this view is once we put them into that position, the blood pressure will decrease, the CVP will go down because we're draining blood away from the chest where we're operating. We don't give heparin until all the cannulation sutures are in place. And we really try to minimize blood loss as much as possible during sternotomy and cannulation. Once the arterial line is cannulated, we then give heparin. We start our suckers after an ACT of 300. And then we put in our venous cannula, you can see there. As soon as the venous cannula is in, then what we do is we have the anesthesiologist shut off the inhalation anesthesia, and then they will go into the head down position. You can see the patient being moved, and as you can see, as they're going more and more head down, you'll see the CVP rise as blood gets back into the heart, which can then be drained. So what you'll see here, the first portion of this is now the head is down, the anesthesia is minimized, and now we're going to drain blood. So the first amount of blood pushes the prime. You can see the prime being pushed out. Now that's collected in one bag. As soon as the blood is hit, you'll see they will turn off the prime bag, and then we will now collect blood. That blood, very, very cheap blood bag. We use a liter blood bag. If we have a big patient, we'll put 2 online, and you can see that is stored and kept in continuity with the patient to adhere to the Jehovah's Witness principles, and then it's given back to the patient after pump. After we get this blood, we go on cardiopulmonary bypass, and then we will go ahead and on pump, we will then go ahead and reposition this patient, and we will have them go head up for us to perform our surgery. Postoperative management, renal dysfunction is one of the biggest problems, especially because we run them with low hematocrit, so the delivery of oxygen is lower. We use renal dopamine until the creatinine crest postoperatively, so all our patients get renal dopamine. We use large cannulas to maintain high bypass flows, and the DO2 are greater than 350 on pump. We avoid pressors. We minimize lab checks. We give albumin bombs for volume. We keep them intubated until cardiac function and mental status normalize, because you don't want to increase their workload. We start 20,000 units of epigen daily and iron daily until their hemoglobin goes beyond 10. And we accept very low hemoglobins. This is something that is really a team effort that we've done in the ICU. When somebody has a hemoglobin of 6.5, they don't panic. And we just realize they're going to be tachycardic, they're going to be hemodiluted, the patients are going to be fatigued. Just keep giving them the epigen and iron. About 4 or 5 days, they will reverse and they'll get better. So results of heart transplant, this is from the 2023 IACHLT. You can see the 5-year survival for heart transplant is 75%, 10-year survival is 65%, and the 20-year survival is 40%. This, of course, is in the cohort of patients that were done in 1992. So all these numbers are even better now and will get reported in 2043 when I'm retired and gone. But these numbers will get better. Now, if you put these in perspective, look at the 10-year survival of 65% and the 20-year survival of 40%. If you look at patients just having coronary artery bypass surgery, their 10-year survival is 69%, and their 20-year survival is 22%. This is the cohort of patients between 60 and 70 years of age. Remember, the mean transplant age is about 62. So a patient getting a transplant almost does better than a patient getting bypass surgery. That's how good transplant is these days. I'm going to talk to you about our Jehovah's Witness results are in patients who definitively refuse transfusion. This is all data that's going to be published in the Journal of Thoracic and Cardiovascular Surgery. This is a pre-publication data set. The advantage of doing bloodless patients is, in general, they're generally a healthier lifestyle. They don't really drink or smoke, and they don't have the bad effects of transfusions. But there are death and complications that can be due to refusal of blood transfusions. In our program, over the last 11 years, we've done 65 heart transplants, which by far is the largest in the world experience by any center. We've done 10 in 2024. A third of these are reoperation sternotomy. So we do not shy away from doing difficult cases, oftentimes multiple reoperative sternotomies. Our 1-year survival is 95%, which is as good as or better than our non-bloodless patients. You know, we lost 3 patients out of the 60. We had 1 patient who we actually did world's first on, which was a situs inversus heart kidney transplant. Unfortunately, she aspirated and ended up requiring ECMO, and her hemoglobin were just way too low on ECMO, and she ended up expiring. We had 1 patient tamponade after biopsy, and another one aspirated after a trach removal. We've had some other failures, but as you can see, other than the hemorrhagic pancreatitis and the ECMO patient, almost none of those patients are dying because of refusal of blood. Some of the challenges we have are patients come from very far distances to seek this extraordinary care. And so they need to relocate to Chicago. Oftentimes we get very late referrals, and by that time their liver and kidneys are bad. So that causes problems for us. Insurance in the US, you know, now they have these Medicare disadvantage plans that are very restrictive. So we have a lot of challenges, but we are able to provide care to a large group of patients. The nice thing about bloodless surgery is that it makes you so meticulous and good. It actually allows us to have things like great leapfrog hospital safety grades, and allows us to have an extraordinary transplant program in general. You can see that over the years, this is not transplants alone, but this is all bloodless surgery. We've had patients referred to us from 47 out of the 50 states in the United States, and we see a variety of cases that are transplants. Most of these are very, very challenging cases that are been refused by multiple centers. So in summary, you know, with a dedicated and passionate team, you know, we have bloodless coordinators. You know, we have 2 bloodless coordinators, and Maureen and Lance, and Andre is our liaison with the outside world. And we have our hospital liaison committee. These are volunteer Jehovah's Witness, extraordinary human beings who actually make life easier for the people who have had to relocate to Chicago. Combining our coordinators with meticulous surgical care, you know, we accept challenges, we anticipate problems, we try to prevent them from becoming real problems. You know, we try to be honest with what we can provide, and we respect their beliefs. And with that, a lot of preparation and good fortune, you know, we have proven that the most complex heart transplantation is possible completely bloodlessly with excellent results. Thank you very much.
Thank you so much, Dr. Jivanandan. That was a masterclass in bloodless cardiac transplants, and truly it is the stuff of legends. That was wonderful. Thank you. So
Thank you for the opportunity.
My privilege. So we're going on to the next lecture, which is on the topic miniaturization of CPB machine for asanguinous prime, a giant leap in bloodless pediatric cardiac surgery. And that talk is going to be given by Ron Angona, who is a perfusionist. Ron is a graduate of the cardiovascular perfusion program at State University of New York, Upstate Medical University in Syracuse, New York, and has been practicing perfusion for 25 years. He has graduate degrees in medical management and masters in business administration. The medical management degree was in 2014, and the masters in business administration was 2021 from the Simon School of Business at the University of Rochester in Rochester, New York. Ron's career in perfusion encompasses both pediatric and adult cardiac surgery, as well as adult and pediatric ECMO. He currently exclusively practices pediatric stroke congenital perfusion and has been the Chief of Pediatric Perfusion at the University of Rochester since 2018. Ron is active in his professional societies, including AMSECT, the American Society of Extracorporeal Technology, and the American Academy of Cardiovascular Perfusion. Throughout his career, Ron has presented on multiple topics, planned and hosted several conferences, and he led the National Pediatric Perfusion Committee for many years. He has also been involved in numerous research publications around a variety of topics. His interests include blood conservation during pediatric cardiac surgery, as well as establishment of standards and guidelines for pediatric perfusion practice. So obviously, Ron is the best person to talk to us on miniaturization of cardiopulmonary bypass machine for asanguineous prime, a giant leap in bloodless pediatric cardiac surgery. Over to you, Ron.
Great. Thank you, Dr. Usoro. Wonderful introduction, very flattering. I'm very honored to be here and be able to represent the perfusion community at the BMSS conference. So thank you to the planners for inviting me. I'm going to talk about some technical innovation in pediatric bypass and how it impacts blood usage. I don't have any disclosures. What I will say is, there's a lot of variety of attendees here, surgeons, both cardiac and non-cardiac, the same with anesthesia, cardiac, non-cardiac. And I think, to some of you, some of the things I'm going to go over are going to be very familiar. And to those people, I hope I can provide maybe a new nugget that you weren't aware of, or at least an entertaining spin. And if you're a non-physician, blood bank person, or in the blood management space, and this is all foreign to you, hopefully I'm going to take a couple steps back and I'm going to really do this from kind of a ground level talk, because in order to talk about things like circuit miniaturization and bypass, you really have to understand how bypass works. Otherwise, I'm just going to be telling you things that you don't understand. So I'm going to talk about the different equipment and methods available to perfusionists and our teams to achieve circuit miniaturization, reducing prime volume and surface area. I'm going to highlight some of the literature, do a little benchmarking, and then show some results of a recent quality project we did in Rochester. And then I am also going to discuss RAP, which Dr. Jivanandam touched on last talk. I'm going to maybe get a little bit more in depth with that, but that's only going to be the last 5 or 6 minutes. So blood conservation techniques that we use at Golisano Children's Hospital in Rochester here, honestly, they do start with surgical precision and anesthetic management. Previous speaker touched on surgical precision, and I'll commend him for his efforts, as well as those amazing surgical videos. Done adult heart transplant, that is not universally adopted, those practices, but it looks like they're really doing some amazing work there. And also from an anesthetic standpoint, fluid management, management of level of sedation, appropriate administration of blood products is incredibly important to all of our blood conservation efforts. Without those two components, really, it can undermine anything that the best perfusion practice can do. But I'm going to stay in my lane and talk about things specific to perfusion. I've talked about transfusion triggers at other conferences. We do accept very low hemoglobins here in Rochester. That's a strategy across the board, and we do quite a bit with blood cell saver reinfusion. We've presented and published on our 24-hour reinfusion practices. But I'm going to talk about today the circuit miniaturization will be the bulk of it, and then RAP and also VAP. So the first thing to talk about is this concept of prime volume. What is it and why do we care? So a couple pictures here. If you've never seen a bypass circuit before, which I think many of you probably haven't, this is what it looks like on the left. This is a pediatric bypass circuit. It's pretty advanced. It looks pretty confusing. Basically, what the takeaway is, it's a bunch of plastic and metal and tubing all connected together that will eventually have a patient's blood flow through it. We assemble it every morning, and then we have to what we call prime it. We have to get all the air out, kind of like a giant IV or giant arterial line, because we can't embolize the patient with air. The moment that we go on bypass and we initiate the bypass circulation, you can see the picture in the middle and the picture on the right. The circuit turns red with the contribution of the patient's blood. So the prime volume in concept is the amount of volume that's contained within all that plastic. And we care because of this thing called the dilutional effect. So if you think about an adult my size, has a blood volume of 5 or 6 liters. An average bypass circuit nowadays can be around a liter, a little bit less, a little bit more. If you start with a hematocrit of 38, you can do this really easy back of the napkin calculation, figure out a red cell volume, and what we call a resultant hematocrit on bypass. And that's the dilutional effect of what would happen to an adult. Most of that would be absorbed by an average adult and wouldn't require exposure to donor blood. But if you look at a comparable baby, which has a blood volume of only a couple hundred milliliters, the bypass circuit volume can basically approach or even exceed the patient's blood volume. So whereas that other starting hematocrit went from 38 to 31, now we're going to actually drop to probably an unacceptably low level at the moment that we go on bypass if we don't make any efforts toward shrinking down the circuit or other interventions. And this would probably require the kid to get blood not only just during the case, but in the actual prime of the bypass circuit. So if we were to say, drop the prime volume of the bypass circuit down to 150 mLs, you can see you redo that calculation, and now the hematocrit only drops to 24%. And, that gives us something to work with. We might actually be able to get that kid through without getting blood exposure, or at least maybe less blood exposed to. And in Rochester, over 25 years, we've reduced the overall prime volume of the circuit from about 450 milliliters when I started my career down to the current level of about 150, maybe even a little lower. And on the left, we have a list of the ways that we do that when we talk about bypass equipment and how we actually reduce prime volume. We can manipulate the disposable components, the tubing size, the tubing length, and do some things with pump position. And that's what I'm going to focus the majority of my talk on. So again, if you're not familiar with bypass, this will maybe be a good explanation. Talking about the disposable components, the brains of the bypass circuit is the oxygenator. The oxygenator does obviously the oxygenation, all the gas exchange, as well as the heat exchange, and also in modern bypass, the filtration of the bypass circuit. And I put up here what we call a flow chart. Oxygenators come in different sizes. And from the smallest to the largest, there's quite the variability in prime volume. And the reason why is they get bigger and bigger and bigger to support larger and larger patients. And the trick when you're talking about miniaturizing bypass circuits or things like that is to really what we call right sizing the size of the oxygenator to the requirements of the patient. So in the morning, we put our heads together. We say, okay, how big is this patient? What kind of flow rate do they need to be able to support them? Which oxygenator should we use? And the tighter that we control that range, one of the vendors called it prescriptive oxygenation, not too big, not too small, picking really just the right size oxygenator for that patient. Not really a whole lot to talk about there. The other components of the bypass circuit, the cardioplegia is a system that we use to stop the heart. The hemoconcentrator, you can think of as an artificial kidney. It's kind of a mini dialysis filter that we use to remove volume during the bypass run. And then arterial line filters are a little bit dated, but they also come in different sizes. All three of these things come in different sizes that are paired to their functionality, how big of a patient they can support based on how big of a prime volume they contain. And there's a trade-off there. Really, the take home here, there's only 2 or 3 bypass manufacturer companies in the US, and there really hasn't been a meaningful contribution from a product development standpoint in probably the last 10 to 15 years. So pretty much everybody around the country is already using the smallest of the small equipment. We might use tighter and tighter ranges with some variability in between programs. We might push some of these items beyond their recommended utilization. But in general, there's not really much technology here to be done anything with at this point. So we move on to changing the tubing diameter. And this is just fighting with physics here, basically. Tubing comes in different diameters from the smallest to the largest. There's quite the variability in what we say is volume per foot. Seems pretty obvious. And the question here is, how much do we need? The bypass circuit, all those components are connected together with a bunch of plastic tubing. And, depending on how big the patient is and how much we need to support the patient, we have to incrementally increase the size of both the arterial and the venous lines and all that line in between. And there's also some other lines within the bypass circuit that can be changed diameter, depending on the arterial side, how much flow do we need to support the patient? Because as you pump more and more and more flow in liters per minute through the same size tubing, the pressure goes up. And then at some point, the pressure becomes unacceptably high because it damages red blood cells, and there can be other issues with that. On the venous side, we have to drain the patient to initiate cardiopulmonary bypass, and smaller lines permit less drainage. So again, in the morning, we put our heads together, we decide how big should these lines be, and we really try to right size the lines. And again, there's ways that perfusionists can push the limited rates above what is a recommended max, but that's not the best strategy. So again, changing tubing diameter has some influence on blood utilization and circuit miniaturization, but not the most. The coolest thing we can do is to impact tubing length. Again, the bypass machine has all these tubes connecting the components together. And with the combination now of the technology that's available and some perfusion innovation, we can really manipulate the overall prime volume of the circuit. So here's my little goofy schematic. Bear with me here. My audio video traits are poor. Patient on an operating room table. The hollow orange circles are the personnel around the surgical field, the surgeon, the assistant, the scrub nurse. The rectangle with the 4 filled-in circles is the bypass machine, and you can see the position of a normal bypass machine, and those 2 lines that go up into the patient's chest are the arterial and the venous lines that carry the blood to and from the patient. And you can see it's very flowy, and that is a normal configuration of a bypass circuit that we would call off the hip. Very easy manipulation that we have done here in Rochester, probably a little more than 10 years ago now, that many centers still haven't adopted, is you can move that bypass machine to a position that we call off the shoulder. And that really dramatically shortens the length of the bypass lines and allows for a smaller prime volume of the circuit. Clinically, here's some pictures. On the left, we call this off the hip, and you can just see in the position in the operating room. And on the right, that's off the shoulder. And it requires buy-in from everybody in the operating room, the surgeon, the anesthesia team, even the echocardiographer, the person harvesting vein from the leg if you're doing adults. It does take some planning, but it's a very simple and inexpensive thing to do that really dramatically reduces the prime volume. And what I'll show you here, just a little sidebar, this is called the pack spec, or it's kind of like an architectural drawing of our bypass circuit. And every perfusion department for each one of their bypass packs has one of these that they work with the vendor to put together. It shows basically all the different lengths and tinker toy pieces of every bypass circuit. And the orange circles here, I'm showing you the length. The very last number is actually the length of the line in inches. On the left is the infant pack drawing from 2005, and on the right is our drawing 20 years later. And you can see we've gone from 75 inches to 35, from 86 to 34, etc. Really, really condensing the size of the circuit. And this is all great, and it changes the prime volume pretty dramatically. It does have some downsides, which I'll talk about. So now we've got this pump off the head of the shoulder of the patient, and this is doing great. And you can see the bypass machine with the 4 pumps across the base. This is called the base mounted configuration, or kind of a linear configuration. But now the technology has enabled us to do this neat thing that we call a mast mounted or a modular configuration. So now we've been able to move the pumps off the base, which we previously weren't really able to do, and get all the pumps closer, even closer to the surgical field, further reducing the overall line length. So here's the pump on the left, which was our old off-the-shoulder pick. You can see the pumps across the base in a normal bypass configuration. And on the right, we've moved to the modular configuration. You can see a bunch of remote screens. Looks a little bit more confusing, and I'll show some better views of this and hopefully give you some perspective on what this looks like. In relation to the field, we're kind of snugged right up to the surgical field. We really eliminate any wasteful space between the surgical personnel and the bypass machine. Certainly, one of the things that we have to consider here is visualization and safety. From a comparative standpoint, the neatest picture here is on the right. That's my hand in the bypass circuit. You can see how compressed everything is in relation to each other, all the different components and the pumps and the tubing. It does give some trade-offs when we go to this mast-mounted configuration. You kind of can't have it both ways. You don't have a lot of areas to see things very well, so you have to be really thoughtful when you move to this kind of a configuration. And again, back to the technology, the bypass manufacturers have enabled this by designing some really, really neat features. The kind of that bottom left, you can see that turret configuration. These modular pumps are now basically can be mounted to an IV pole. They're smaller. This isn't incredibly new. These have been out for 10, 12 years, but the bypass manufacturers continue to innovate and allow us to rotate the pumps, pair them together in different ways electronically, mount them remotely so that we don't have to be able to access them. And then perfusionists have gotten really creative with how they approximate things near each other. The picture in the middle is really cool. If you're not a perfusionist, you may not appreciate it. But basically what I'm showing here is that we've eliminated the tubing. It comes right out of the oxygenator, right into a connector, and there's just no wasted prime volume anywhere. And then this last picture shows how it's snugged right up against the surgical field, right up against the surgeon's left hip with very little visualization. But again, really allows us to reduce the prime volume and the dilutional effect. This has been well published in the literature for the last, since the late 90s, really. Perfusion is publishing all angles of this, showing off their circuits and their technique, their numbers, the impact on blood transfusion requirement and things like that. And it's continued right up into the modern day with things like mounting the bypass circuit to the operating room table. And now we're doing bloodless arterial switch and neonates and even Norwoods being published on, which wouldn't have been possible even in the last 10 years or so. We also do a international benchmarking survey. A group of perfusionists put this out every 5 years or so. It was previously called the Groom Survey, if you're familiar with that. And it shows the worldwide average of prime volume of your neonatal circuit. And Rochester's always been right there. We contribute to the survey, and it helps us look at other people's benchmarking. But we did decide to continue to push about a year and a half ago. We felt like we had room to grow. So we did incorporate a couple more of those mast mount pumps. We developed an even smaller pack, and we further miniaturized the current circuit that we have by reducing the length of some other lines and as well as the diameter. And the reason why we did this, this is a case that struck me as a mid-sized kid, not a neonate per se, but in that 6-7 kilo range, which our blood usage in Rochester is very spectacular by anybody's metric, but there's always room to do better. And this was a kid who was really close, but due to some patient-specific factors, we wanted the hemoglobin to be a little bit higher at the time that we discontinued bypass. So we ended up giving this kid a little bit of blood. And again, by anybody else's standard, this would probably have been a success. But given that the kid didn't get any more blood throughout his hospital admission, and this is possibly a one and done case, actually, no, I'm lying there. It just showed how close we were to being able to get through this case bloodless. And if we could make some incremental gains, we might be able to get over the hump here. So we did set some goals. We wanted to increase the number of bloodless primes, which I'll talk about in a little bit, the overall number of bloodless cases, and also the kids who did give blood, we wanted to try to give less blood, and we can talk about whether that's useful or not. There's a group in Germany, if you haven't read their papers, they've got a series of about 25 papers over the last 10, 12 years around these topics, and they've really done some amazing work with regard to bloodless surgery. So I'm trying to mimic some of the things that they've done. And this was a slide that I put together for a perfusion meeting, but bear with me. It kind of breaks down all the different lengths of the tubing around the bypass circuit. And in general, you can just say on the circuit on the left was the older version, on the right is the newer version. And these numbers don't exactly match up to that survey for a variety of reasons, but you can see we made some pretty significant reductions throughout the bypass circuit that do impact the overall usage of blood in a variety of patient populations. And these are just milliliters for different segments of the bypass circuit. There's, of course, limitations, things like visualization that I talked about. We have a thing called a response time. When you are flowing low, as a previous speaker talked about, with lower levels, your safety margins are eroded a bit. Things like microemboli handling and bubble transmission come into play a little bit more. How we would respond in an emergent scenario. And even things like sterility, handing the lines up to the surgical field, being right close to the sterile surgical players. All these things have to be taken into consideration, and we do that, but these are all trade-offs that are worthy of discussing. Further to the safety, when I started this project with my team, really my charge was don't screw anything up. We really do have an awesome system here where we use very, very little blood and blood products. So these gains we knew from the beginning were going to be marginal. So we wanted to take a stepwise approach and really look at even from things from lab values, pre-operative lab values to post and time to baseline to make sure that there weren't any things that kind of unforeseen consequences that we brought into play by being more aggressive here. And even subjectively, things like quality of bypass, super important to have great drainage and great line pressure. For those of you who live in the bypass space, having good bypass is just fundamental to having a good surgical outcome. So we really were constantly getting feedback from the surgical team and everybody to make sure that we didn't have any unforeseen consequences. And we had some early success here. Patient on the left was who I showed you before. The one on the right was a kid who was about the same size, but started out with an even lower hemoglobin. And that child, because of the new circuit and the improvements, we were able to get through the entire hospital course with no blood or blood products. And even our ICU attending friends threw us a bone here and made sure that everybody knew that we did asanguinous cardiopulmonary bypass. Because one of the things that happens when you do this and you really employ the technology is what we like to say is we make really, really nice cases way harder. It would be easy to Dr. Spiess's end here to just give a patient blood. It fixes all the numbers, and everybody, you know, has this level of happiness. But are we really doing anything good? And this is torture for a perfusionist for an hour, hour and a half to have all these little nuancy things that we're trying to make better when we could just give blood. So it was nice to see that they were trying to support our efforts here. And this is a very, not a complete data analysis at all. Our older cohort, I really tried to break down by pathology as well as size and starting hematocrit. Starting hematocrit is super influential on the need for blood. So you can see this is tetralogy of Fallot, a common pediatric congenital repair. In the old cohort, most of the kids got blood and very few of them were able to get clear asanguinous primes. But in the new group, all had asanguinous primes and only a little more than half of them got blood. And again, these are small numbers. This is a baby, like a 3 kilo total veins, only one patient. Both of these patients in our practice are still going to unfortunately get a blood prime right now, but we were able to reduce the amount of blood that we gave. And these gains have continued as we've continued to use this circuit. So our goals, we were able to increase the number of bloodless primes fairly significantly, the overall number of bloodless cases, and drop the amount of blood that we use per case. And we've made some improvements even since then. So I'm going to shift gears here in my last 5 minutes or so, 6 minutes, and I'm going to talk about RAP and VAP again. I know Dr. Peter Knight here in Rochester talked about this at BMSS last year as well, but I'm going to give you a perfusion spin on it and kind of show you some videos on how we do it. RAP, as previously mentioned, not to belabor this, is retrograde autologous priming, but to break that down, retrograde flow obviously is reverse. We're using the patient's autologous own blood to basically displace or reprime the bypass circuit. So I showed you in the beginning how we have to prime the bypass circuit with clear solution, usually plasma light or whatever in the morning. RAP allows us to displace a portion of this clear prime into a collection bag, and therefore the patient's not diluted by as much crystalloid. It obviously only works when you have an asanguinous prime. If you do have to do a blood prime, RAP isn't really applicable for that. It was originally described in the adult perfusion literature, but it's being adopted in pediatrics, and we've even brought it into the infant population. It obviously has to be done carefully. As mentioned, it's basically controlled exsanguination of the patient. You have to monitor hemodynamic stability and blood pressure. And obviously the big trick here is the anesthesia team has to manage the patient's mean pressure by using pressors as well as bed position. They can't be giving fluid to treat hypotension because then we're just chasing our tail. And if you do this right, you mitigate the dilutional effect of bypass. So here's a video here, and I'm going to mute this out. This is a RAP in the adult population. The video is a little choppy because I cut out some sections in the interest of time, but you're going to see blood flow retrograde down the arterial line at the moment that we institute RAP. And again, I'll tell you when this happens in a bypass case in just a moment. So here's the blood coming retrograde down the arterial line. There's the hemodynamic picture. Sorry. There's the blood coming retrograde down the arterial line, all the way back to the oxygenator. The first stop is the oxygenator, and we'll pan out and I'll show you the collection bag where that displaced volume is going into right there. There's the collection bag, and the blood will come down the arterial line and eventually hit the oxygenator. And the oxygenator that will show you, it's a standard adult oxygenator that has a prime volume in and of itself of about 230 milliliters. So that's a lot of clear volume. And this patient tolerates it very well. Patients usually have some excess volume. You can see the blood displacing the crystalloid. You get this really cool effect, kind of like a lava lamp. Very satisfying to see all that dilutional effect go away. If you don't know what a lava lamp is because you're young, you can Google that. Another video here from my colleagues at Nationwide sent me this last week very kindly. This is WRAP in infant patient. This is a smaller reservoir and oxygenator. But in concept, the same thing. They're going to flow retrograde down the arterial line. And you'll see that right there coming around and down. It happens a little bit slower here. We have to be careful. And you're going to see, you can actually, in a clear video, you can see the pulsatility of the blood coming down the arterial line, which is kind of cool there. And then eventually it'll come back into the oxygenator and they'll displace all the volume in this oxygenator, which has a prime volume of about 42 milliliters. And again, we'll pan out to the collection bag, same bag. And the perfusionist does this through the manipulation of a series of clamps and stopcocks. And again, this takes some time and it has to be done well. The last video I'm going to show you is what we call, last video I'm going to show you is what we call VAP. And VAP is venous autologous prime. So this is taking it to yet another level. And this is right before we institute cardiopulmonary bypass. When the venous cannula is in and connect to the venous line, the perfusionist is going to open that clamp and they're going to permit some of the venous drainage to come down into the reservoir. But rather than perfuse it back through the arterial cannula, they're going to move some clamps and some stopcocks around, and they're going to use the bypass pump to chase out that extra volume into the collection bag as well. So here we go. And you'll see he opens the clamp, lets that blood come down the line, reclamps it, and then moves some things around. Here's your hemodynamic picture. Nice blood pressure, 65/24. The anesthesiologist was supporting that with some Trendelenburg position. Now we're advancing the arterial pump, but again, we're not pumping to the patient. We're pumping into a bag through the manifold there and wringing out some of that clear solution. And they'll do this 2 or 3 times as the hemodynamic picture permits. You see he'll open the clamp again, allow a little bit more blood to come down into the reservoir, chased out through the pump. And you can do this intermittently, and eventually you can get rid of a good portion of that clear prime in the bypass circuit. So not so much a technical innovation or innovation with the technology, but more of a technique that's being adopted by perfusion teams that's free and works very well. Schematically, real quick, I'll just show you what this means. In the top left, figure 1, that's WRAP. So you have a patient and you have flow retrograde down the arterial line through the oxygenator into a collection bag. The bottom left picture is VAP, venous autologous prime, blood coming from the patient down the venous line into the reservoir through the pump, through the oxygenator, and again into a collection bag. And the third picture in the bottom right, that's the normal bypass flow. If you haven't seen this before, blood comes out of the patient, down the venous line, into the reservoir, through the pump and the oxygenator, and then back up the arterial line. From a timing standpoint, WRAP happens. The first step in cardiopulmonary bypass is heparinization. We can't do any of this until we're heparinized, the blood's anticoagulated. Then the first thing is we place the arterial cannula. At that point, we connect the bypass circuit to the arterial cannula, and that's when we start WRAP. But it's before we go on full cardiopulmonary bypass. It takes 2 to 3 minutes, and if you do it well, you can get off 2/3, 3/4, or even more of the volume in the bypass circuit. It's safe, it decreases intraoperative blood transfusions, results in a higher crit on bypass. Clinical outcomes are mixed, tons of publications in the space showing variety of impacts on vent times and total transfusions. But in our practice, we believe it's very safe. We apply it to every patient who doesn't get a blood prime, and we're pretty aggressive with this. The last thing I'll show you here, just some math and how this actually works. I showed you the column on the left earlier, a neonate with a prime volume of 150. What WRAP does is it effectively reduces the circuit volume. If we say we took off 2/3, we're taking out 100 milliliters. So now we're changing the denominator, and basically instead of diluting the patient to 24, we're only diluting them to 31. And now that gives us something to work with. Now we can run the bypass case at that level, and we may be able to get through the entire case without having to give any volume or any donor blood. In conclusion, in our practice, we've combined circuit size reduction and WRAP to enable our kids to get less blood and also have a less frequency of being exposed to donor blood. We have some difficult patients still, kids that have pulmonary hypertension or start out anemic. are very frustrating. The question is, are we still making a difference? If you have to give some blood, doesn't matter. Is there a dose response to washed red blood cells? This can be debated, and I'd love to understand what the answer to that is. And do the reductions in blood usage outweigh the trade-offs in safety and cost visualization? Should we keep pushing? Thank you very much. And again, I appreciate the invitation to participate in your annual conference.
Thank you, Ron. I really appreciate your talk. That was great. And I tell you, if you're getting involved in patient blood management, meeting up with your perfusionist, they're a great part of your team. And I've always considered it a really safe place to go and meet with the perfusionist. Their ability to multitask and be able to talk to you and help you understand what's going on in the world of patient blood management is just so helpful. So really go meet them and sit some time with them, and they're a great resource of information. So the next speaker, I know we're going a little bit over time, but hang in there with us because this conference is being recorded and will always be available to you. So hang in there with us. The next speaker I'd like to introduce is I don't want to mess up this introduction and the first name, but Johan Rebello. And he's an engineer and has worked in the healthcare field since 2011. He is currently head of innovation at the Heart Institute in Sao Paulo and coordinator of the PBM project at the Brazilian Association of Hematology and Hemotherapy. He also is a board member of SABM and vice president of SABM. He's an MBA professor in health tech and healthcare innovation, and I'm happy to introduce Mr. Robello.
Thank you very much, Marianne. Do you hear me well? Yes?
Yes.
Okay. I just need to change my presentation. There's someone presenting still. Let me just share my screen.
Okay.
And well, I think everybody can see now.
Yes.
And okay, so thank you very much, and all the members of the committee for the invitation to share with you this topic that is very interesting also because not only clinical aspects are important for patient blood management, but technology from the science and artificial intelligence is reaching us too. So I will be talking to you in the next few minutes about transforming healthcare and bloodless medicine using artificial intelligence, showing that the future is now. I have no conflict of interest for this particular presentation, and my objectives to the presentation will be to understand how artificial intelligence is inserted in health and medicine today, also the potential applications of AI in PBM, some examples of current use and the future trends, how we should look into the future of including AI as a potential collaborator for our use to patients. I'll start with Dr. Topol. He's a famous cardiologist and a technical savvy person. He mentioned that as always regarding technology that we try to beat machines. So man versus machine is the topic, but with few exceptions, we should look into man plus machines. And AI fits into this configuration. We see that AI is reshaping every aspect of medicine today, from radiology to drug discovery, and PBM is no exception to this rule. So what's the current scenario and the challenges we have when considering AI? First, we need to understand that we are around data all the day in medicine today. So privacy and governance, protection of sensitive data, compliance rules by law, and controlled access is a must when we are talking about using data, especially from the patients. Also, we need to understand that interoperability is also a big challenge because we sometimes lack standardization across electronic medical records, systems, fragmented data. So this is an important architectural issue when we're using AI. And of course, quality and representativeness, because data sets that are incomplete, that has bias, outdated data, they all compromise AI reliability. So we must be sure that we are using reliable data. And the AI toolbox for medicine is not just one type of AI technology, like we saw from my predecessors on their excellent presentations. We also have different sort of approaches from technical aspects in AI. We have machine learning, computer vision, deep learning, cognitive computing, natural language processing, and also neural networks. All of them are different tools that we should be considering when using AI in medicine. And because of that, we can have different approaches to pre-operative decision-making process, risk assessment, intraoperative support, and also guiding precise post-operative plans to optimize outcomes of our patients. We're going to talk about a little bit this during the presentation. What are the scenarios we handle today? First, we are seeing AI a lot in the diagnostic environment. Radiology, pathology, dermatology, all of them are using AI to detect diseases earlier, and the earlier the best, and with more accuracy. But also, AI has been introduced on decision support process with clinical AI models to help predict sepsis, cardiac arrest, and also ICU deterioration. So the data is supporting the decision process, not making them. And during the operational part, AI is also supporting hospital logistics. And we evaluate our bed flow, and we see if we can improve our surgical scheduling. So improve how much we can use the infrastructure and the workflow in our hospitals to the best. And finally, AI is also on the regulatory area because many regulatory agencies are looking into more and more solutions that are embedding AI into its framework. Just for an example, the FDA in US has already approved more than 1,200 AI-enabled devices, and this is growing very fast. Recently, FDA released information about how much AI product has been pushed through regulatory process. And this year alone, they are looking into 300 new approvals that are based on AI. So we are seeing more and more tools getting to us. But the question is, are they good? Can we use them? And if we can, where are they best fit? So the question to us is, if AI is already changing the medicine domain, what can they do to patient blood management? That is an important question. We have some potential applications. Not everywhere in the world are accessing them at the same time, but we need to understand where they apply. So these are usually the areas where AI have applications. So we have different tools, but if you look into the articles and the publications showing where AI has been applied, I would say that PBM has a lot of these areas with current technology and techniques being applied based on AI. And is good for us. So people are trying and testing more and more solutions. I'll tell about how they are being done, following Dr. Spee's approach, using the three pillars. So in pillar one, by optimizing red cell mass, we have AI predicting anemia risk pre-surgery. So they are taking data out of the medical record and the lab patterns and trying to see if the patient falls in risk assessment. Also, we have chatbots and virtual assistants that are engaging patients on their pre-op plan, flagging sometimes iron deficiency earlier, so we can understand if we can intervene prior to the surgery. And also the personalized anemia management pathways, because different patients with different comorbidities needs different approaches. So personalizing the care is also important. This is just for pillar one. And do we have articles and data? Yes. These are just a sample of some of the articles and published information on how they are using AI for pillar one. And interesting is some of these applications are done in low-income countries, Ethiopia, sometimes in Africa countries. We are seeing more and more of them trying to use it because of the lack of infrastructure sometimes for doing the screening. So AI can be done in a very limited environment, but with a smart approach. So it's something that we should look into our practice in our hospital area. On pillar two, minimizing blood loss, there are also some interesting applications. They are also predicting the bleeding risk during surgery. We have computer vision is how the computer cameras and images can assist in the surgical field, the hemostasias or visualization of bleeding spots. So this is also something that is addressing very fast. If a car can drive themselves, why they cannot be using the cameras and AI to assist during our drive path during surgery? And also controlling perfusion. We just saw an excellent presentation from Dr. Ron about how we can access real data parameters from the perfusionists. So we also can assist the cardiac surgery, the extracorporeal process, and the cell salvage, looking into the data from the machines and trying to optimize the flow, the blood flow. And again, many articles are being published in this field. So we do have access to interesting applications, and we should look into the scenarios that they're using AI and see if they applies to our own environment. Maybe we can try some of their approaches, especially running the data to assess risk. This is a very important thing. And pillar three, we have the optimization of transfusion decisions. Well, AI can support decision for thresholds, especially adjusting for patients' comorbidities, their own physiology, and predicting outcome. Especially on the recovery side or ICU patients, they have a lot of data that are being generated constantly. So to evaluate such data in a very effective way, we can use AI to support decision. Also, the predictive models. Can we estimate the tolerance of anemia for a specific person instead of just using a generic protocol? If we do this, we can reduce unnecessary transfusion by personalizing care. And also smart monitoring. AI can analyze continuously the vitals and the lab information from the patient and intervene, of course, in the matter on the best moment, or supporting the team to intervene. And this is timely and sensitive for patients. So these are just information. And we have also a number of articles showing what type of applications AI is having. One interesting area that we are trying at our hospital in Brazil is the post-operative phase when we discharge the patient. So we want to measure the patient on their discharge effectively and safely to see on the post-operative phase, maybe during the first 30 days, patient is doing well, and we are collecting data and analyzing through AI for telemonitoring. So there are a number of applications that we can use. I'll show now some examples on how we are using this. This is an example from Portugal, from our colleagues in Portugal, our dear friend Diana Palperio, anesthesiology, and also what they're doing. So when you use AI, you need to evaluate what type of parameters you are considering as vectors to potentialize the understanding of the assessment. So this is one interesting case when they tried to use AI to do support to decision for prioritizing high-risk individuals that can receive PBM intervention. And when they looked into the different parameters, the pre-op hemoglobin was an important parameter for them to make a decision to look into the patient more carefully. But also the target approach was to ensure that the personalized patient-centered care could reduce the workload of health professionals, also improve the overall hospital resource management, and also use wisely blood and the PBM resource. So this means that AI case is a sustainable tool for our use in healthcare. We need to understand that it has to be designed to improve our own resources, and this is also responsibility care of patients. Talking about perfusion, we just had one interesting lecture. The Perfusion Association, International Perfusion Association, is using a type of chatbot that has important database for the perfusionists to access. So instead of using a collective internet-based information, it's using a data set of information that is curated and properly directed to perfusionists. And based on that, the AI model can respond more effectively to the questions from the perfusionist. So it's important for clinical practice, education, and career advancement. So we can target the AI machines to use what we want as basic data, and the response probably will be more effective and more curated. And applying the same concept, we did a case at INCOR. Recently, for our training, we developed a robot based on generative AI to be a PBM cardio navigator. So we know that during the patient path, the care plan can be done in different stages. And this is an interesting article recently published to show that artificial intelligence can help us during different stages of patient care. So we looked into three specific moments. That is the triage, pre-hospital, also the safety assessment of the patient during their arrival at the hospital, and the quality improvement by looking into different data that we support the robot for them to look into lack of data that we are missing. So based on that, we develop a robot. It's our PBM cardio navigator test, and the robot have been loaded and trained based on specific materials and documents. So either protocols, the PBM from WHO policy brief, implementation guidelines, the European and American protocols, and the Brazilian hematology hemotherapy consensus. So all of that was the basis on the robot assessment. So he could not use external data. So this limited the hallucination of the robot, and he is more precise on referencing what data he is going to do the test, the evaluation of the questioning, and the evaluation of the patient care. So we had 4 areas. So patient could be evaluated for a PBM cardiac surgery. We input some data, and the robot evaluates the patient and give us the response based on the documentation. Also, he can generate a checklist of the clinical data that we supported, showing what is there and what is missing. He can also show data gaps for auditing purpose. Does we miss, for example, a consent term? Do we miss some lab test? So this also improves the workflow for the nurses. And also classifying transfusional risk based on the data and on the protocols that is referenced. So this is one thing that we are trying to use to help improve the quality of care for our patients. We have also some point of care applications that is used based on computational visioning part. And based on that, we can use, for example, for anemia triage, simple measuring by the nails. So we can take a picture of the nails, and based on the nails, computer vision can improve the quality of the triage to see if patient is anemic or not. Is this a diagnostic thing? No, this is a supportive for triage. Based on that, you can send patients to triage and do, for example, a follow-up lab exam. Also, we are testing now, we are putting a new protocol based on this app. This is based on the exam from the eye, the sclera of the eye. And we are going to use on a multi-center protocol very soon, using this simple measure based on the eye picture, how much the patient could be anemic or not. So you see, there are different approaches, but all of them use the engine for computer vision, for machine learning, and also AI tools for data analysis. And this could be done easily at any very simple country based on a simple smartphone. So what are the future trends? Just to finalize my presentation. We know that generative AI assistants are going to be part of our daily lives. They can provide instant synthesis of patient status and also guideline information to recommend protocols. Also, we can see digital twin of patients that simulate what surgery will be or transfusion strategies and so on. Also, there are federated learning. Sometimes we don't have enough data to do a model, but we can share data with other on a very secure way. So multi-center AI models will be trained based on collective data. And integration of such data into dashboards to control patients. This is important for real-time decision process, predictive analytics, and also supporting people in different stages based on the information we get. And finally, AI has an impact on economics. We need to do cost reduction today for sustainable healthcare. So the data that we collective gather from patients and care can support better decision process during economic decisions. In patient blood management, AI is not about replacing decisions, but about giving every patient the safest blood management strategy that we can. It's tailored, it's precise, it's timely. So in conclusion, AI is not sci-fi anymore. It's not rock science. It's starting now to be part of our world. Has synergy because it also can be implemented in clinical framework, but also brings prediction and personalization. And is also part of the human plus AI collaboration process. It's not replacement, it's contribution. So we need to look into that very effectively. And final words from Dr. Topol. We started with him, we end with him. So this moment we live is probably the biggest transformation of medicine in history because we are in the early stages and we see a lot of potential ahead. So again, I want to thank you, Mary Jane, Dr. Soro, and many others for allowing me to share this information with you, and looking forward to exchange future challenges using AI in patient blood management. Thank you very much.
Thank you very much. Thank you so much for that presentation, Dr. Abello. Thank you so much. So about now, we're going to be taking the Q&A. We have just one question in the chat box as of now. We're just going to be reading that out because the time is fast spent. So the question here says, when using AI tools, how does it adjust for racial bias or assumptions? How do you determine if AI is hallucinating or making up incorrect data or assessments? All right, Dr. Abello, would you want to step
Sorry,
in?
yes. Can you just repeat the sound just fall?
Okay, all right. So it says, when using AI tools, how does it adjust for racial bias or assumptions? That's the first part of it.
Okay. Well, that's important for racial bias and other, I would say, natural bias that any clinical application have. We need to adjust this based on the algorithm, okay, and the data set. So as you have in clinical data trials, if you test a drug on a specific population set, sometimes you cannot extrapolate to everybody. Okay, we need to diversify the application of a medication or something else. So the data for AI is the same. We need to make sure that the algorithm is preset to consider different population, and also that the data that backs the algorithm comes from different population sets. This reduces the bias.
All right, thank you so much, Prof. The next question says, how do you determine if AI is hallucinating or making up incorrect data or assessments?
Well, hallucination is a process of the AI learning, and we need to reduce it by reducing the information that you provide to the algorithm to use as the reference. So when you give the freedom of choose information, sometimes the AI machine will look into different kinds of information backgrounds. So it goes to the general internet and so on. So it can hallucinate what you are looking into. And you need to instruct the AI algorithm and the machine, for example, to not be prescriptive. So the one that we did at my hospital, we blocked the prescriptive version, so it could not indicate what type of drug it should use or dosage. So you block the functions, and you use correct and very validated machines referencing based on the documentation you upload to the robot. So it will be sure that we'll reference to guidelines, documentation that you trust. So basically, that is how you reduce hallucination and also the bias on the algorithm.
Thank you so much, Prof. Okay, so we have a couple of hands raised. First of all, Dr. Nathaniel, sir.
I think Becky raised her hand first.
Okay, I thought you had
So
something to
let's
say
get
regarding this. All right, so let's begin with yes, Rebecca Rock, please.
Hi, thank you everybody for your wonderful talks today. I have a question that, I wonder if maybe a few of you might be able to answer. I received a really interesting example of one of the challenges with AI from Dr. Ryan Lett, who's a PBM practitioner in Canada. And he was giving an example of trying to utilize AI, putting in some patient scenarios. And no matter what he put in, the AI tool kept telling him the answer is transfuse. And we've heard this many, many times about how, the data coming out is only as good as the data going in. So clearly this is a problem, because if people are going to look towards these tools for solutions like that, instead of using good clinical judgment, looking to the tools for it. But I guess I'm wondering, what can we practitioners of PBM or bloodless medicine and surgery do to contribute to the good data that includes everything that we've been hearing in these lectures and we're going to hear in the next few days, to help AI provide good information, evidence-based information?
I'm so glad that Becky spoke first, because she's speaking my mind. In the Bloodless Medicine and Surgery Society, we're not trying to find out how to transfuse or what situation we should transfuse. We know that there's no situation in which blood transfusion is good. So we're thinking of how not to transfuse, how to do bloodless. So can AI really help us in this regard to do bloodless, or is just repeating the discredited concept of transfusion? Because it's even reflected a bit in the lecture by Professor Rabello, when you're talking about how to transfuse appropriately. That's not what we discussed here. We're discussing, we want people to teach us how to do things without blood transfusion. And if AI cannot do that, then I think we're better off with the humans.
So can I comment on that? And it's a great question by Becky Rock. And I think listening to Guillermo Rabello speak, it brings up the thought, that AI, if it's historically looking at what best practice is, then it's going to look historically. And if you look at our surgeons, and I can't remember his full last name, but the surgeon from Chicago, he used so many things that are just plain not in the medical literature to accomplish what he was trying to accomplish. So AI cannot, at this point, look into his mind to say, if we did everything he was thinking about, we would come out with the bigger outcome. So I think just like the technologies I was pointing out to you, AI is a tool, and AI is an evolutionary tool that will have to evolve. Can AI be out ahead of us? Out ahead of human thinking? That's a question for Guillermo to think about. Is can AI put things together that nobody's ever thought about yet? And I'm sure it can. I'm just not a good enough computer nerd to know how it would be programmed to do that.
Yes, it's a good point, Dr. Spies, and also Becky, great challenge. And I like this type of challenges because when we are talking about AI and everybody looks into it, is they think that AI is a wizard. It's not a wizard. AI is a machine instructed to do some sort of procedures, okay, that can do it faster and with more data that we process on our brains sometimes. But we need to do the correct design. And that's important, Becky, because the design sometimes of the machine algorithm is wrong, because we assume that the machine will learn by itself based on whole history, like Dr. Spee said. So if we load the information that is transfusionist, the machine thinks that this is the pattern that it needs to follow, right? So it's like a young resident that everybody teaches them to transfuse. The machine said, oh, that's the correct one. But we have different methodologies today, and one of them that, like Dr. Spee said, can help us is we can load the most recent data sets and the most recent articles that shows PBM path instead of transfusional path, that is not just liberal versus restrictive. It's a different mindset of care with the data, and say, okay, this is the pattern, this is the trend the algorithm should learn. And we use, for example, deep learning. The deep learning is not a process of the machine learning saying, okay, you try to learn this way and you just improve by repeating it. The deep learning is, okay, I have this such information, for example, on the perfusion machine performance, but somehow I don't understand how it may happen or may behave in an unforecast scenario. So the deep learning is, it's going to try to look into the data from a different perspective and say, hey, I found a different pattern. Have you looked into this pattern before? So it shows for us, for example, missing connection or different interrelationship of data. So, for example, we can tell the machine saying, or the algorithm, you don't have blood to give. This is a premise. You don't have premise. Say, you don't have blood. So blood is not an outcome of your analysis. It's everything else outside blood. So what you can use as solutions or proposals based on this. And I can just say, to finish my evaluation, using the Apollo 13 lesson. Everybody probably saw the movie, right? So do you remember the paradigm they had to overcome the concentration of carbon dioxide on the spacecraft? They had square and round filters. So the concentration was going up, and they couldn't use the right filter to change because one of the spacecrafts was shut down. So if you look into the movie, they told the engineers and say, well, you need to use a square filter to fit into a round space with only these tools, because the astronauts doesn't have the luxury to use something else. You need to figure out how to make a whole square fits into a square box. So in a way, we need to do the same, like the spacecraft. We need to figure out how to do things without the preconcept of blood transfusion. And that is not because we don't want to use blood, is that we want to change the mindset of thinking. So that's how we need to tell the machine, you don't have this or that resource, so what is the alternative path? And then the algorithm and the deep learning and all the mechanisms will try to figure out a way. Maybe it would not be the most effective, but maybe at least effective to our thinking. And then we have the final judgment. Sorry for the long answer.
Thank you very much.
In summary, we have to teach AI that blood transfusion is lacking efficacy, has adverse outcomes. It's not a good idea. That what is called alternatives should actually be the first thing, like Dr. Speed said, that should be the default. The bloodless medicine and surgery should be the default position. And then AI will learn.
Yes, for sure, definitely. That's the preset that you need to give to the AI algorithm to think first on not giving, and the blood transfusion is the ultimate last resource. Then that's how the machine will learn.
Over to you, Udak.
All right, thank you very much, Prof, for answering those questions. So further questions will be answered in the Q&A session. We have to run now. Thank you so much. We're grateful to all the speakers for today, the panelists are available, of course, and then every attendee and the co-moderators, of course. Also grateful that you joined us today. We're moving on to the oral abstract section. And for this, we're going to be having Dr. Prabhu Nesajika. I hope I didn't pronounce that wrongly, as well as Melissa Poland.
Hello, we would like to welcome you to the first oral abstract session of this conference. My name is Melissa Poland. I am a registered nurse and the clinical coordinator for bloodless medicine and patient blood management at Montefiore St. Luke's Memorial Hospital in Newburgh, New York. With me is our co-moderator, Dr. Nasarkar. Very happy to have him. He is a consultant of upper GI cancer, bariatric, and advanced endoscopic surgeon at HCG Hospital in India. We have 3 wonderful abstracts to present today. Each presenter will have about 10 minutes, and then we'll have a little time for question and answer. So I'd like to introduce our first presenter, which is Dr. Majed Rafai from the University of Rochester Medical Center, Rochester, New York, USA. He'll be sharing with us the abstract, Navigating Ethical and Medical Challenges, Acute Normovolemic Hemodilution, and a High-Risk Jehovah's Witness Patient during cesarean section. Dr. Rafai, you have our attention.
Thank you very much, Melissa. Okay, let me share my slides here. Okay, Melissa, can you see my slides? Okay.
Yes.
Okay, thank you very much. I'm gonna do this really quickly and short as possible. So this is a case of a Jehovah's Witness patient who came for a C-section, and we were trying to use some technique that's never been used before at our OBG unit at University of Rochester. But because of this case, they tried to find for some reason or some way of minimizing blood usage or blood loss because she's a Jehovah's Witness. So, as you know, one of the leading causes of maternal morbidity and mortality is postpartum hemorrhage. And the definition of this in literature is loss of about 1 liter of blood with addition of signs and symptoms of hypovolemia, and usually it happens within about 24 hours of delivery. So the one of the approaches to reduce blood loss is known as acute normovolemic hemodilution, which will be controlled by removing some of the whole blood of the patient's blood prior to surgery and reinfuse this blood toward the end of the procedure. So in this case report, we have a 26-year-old female, pregnant female, who came within 38 weeks and 1 day. So it's very close to her delivery. She has a history of iron deficiency. She has previous 4 C-sections, and she has some also significant facial adhesions. And the BMI was very high of almost 40. So as I said, Jehovah's Witness patient, and she came very late in her pregnancy, seeking another C-section, and she refused any blood products, so including albumin or any blood products in general, animal products, or also hysterectomy, because she's still insisting on continual pregnancies. So she does accept her blood. It's okay with her. And the cell saver usage was okay with her as long as it's not put in a bag and removed from her. She wants the cell saver to be continuous during the procedure. As most of the Jehovah's Witnesses, they require the blood to be continuous during the procedure. So about a few days later, she presented with a rupture of the membranes, and the cell salvage was set up to be used in this case. As mentioned, was Dr. Spies's cell savers usage in OBG is very, very rare in most of the hospitals, including us as well. So it was something new for them to set up cell salvage for this. They placed an arterial line, and the spinal epidural was performed. 16 gauge and 18 gauge needles were placed, and no epinephrine were started. So they remove about 320 ml of whole blood from the patient, and they infused 1 liter of pistol oil at the same time. A gram of calcium, a gram of tranexamic acid, and 3 units of oxycodone were also administered at the same time. So the estimated blood loss, thankfully, wasn't that huge. It was only about 300 cc. And unfortunately, as you know, the cell saver required more than this blood to be used, so it was not even used. So the unit that was collected was infused back again and at the end of the C-section. The hemoglobin before and after wasn't a big difference. Pre-operation hemoglobin was 11.5. The post hemoglobin was 10.9. The patients did well, and she kept her uterus and was a successful procedure. So the after that, so it's the entire case here emphasized on how the team works really very quickly within a few short days of the announcement of this case, and presenting was like 3 to 4 days after that. So we managed to help each other between the anesthesia, the hematology, and the blood bank to fulfill all the requirements of this patient and try to keep her uterus as well, because we were worried about the hysterectomy. As I said, because of a lot of adhesions from previous delivery, and also from the big BMI in this patient. The blood bank team was able to provided some bags and provided some consultations on this case, and we were all waiting for this urgent C-section, and it ended up successfully. I think that's all about my case here. Back to you, Melissa.
Thank you so much, Dr. Rafai. Very interesting. ANH is something we don't normally see in C-section, so it's nice to see it was done successfully, and with 1 week of planning, how you pulled the whole team together to make that happen. Do we have any questions about this wonderful abstract or your presentation? Considering this case, I do have a question. Was this the first time using ANH in a C-section?
Yes. Yes, it was. I mean, as I said, they don't even consider providing the cell saver there. I mean, they don't even have it. So we have to arrange to bring it in to the OB, and we have to arrange all the needed technologies to be there at the same time. Because the refusal of hysterectomy, I mean, they were worried about you don't know what's you're gonna get in because of the multiple adhesions. She has a history of it, and the iron deficiency anemia she has. So it was a lot of factors affecting this. So it was like a first case to use everything of all of what I mentioned here.
So Majid, sorry, I have a question, Majid. So if you said you are a cell saver, so you could go for bloodless surgery per se. So if you think your center gets a cell saver permanently, you'll be choosing more women to go for bloodless cesarean section?
I mean, right now our OB is really very interested in going for as much as possible bloodless and as much as possible use the patient's blood. Because they have more, we have more populations right now of Jehovah's Witness coming back to the hospital. I mean, before that, our hospital was very well known that they are not Jehovah's Witness friendly hospital. Now, with our patient blood management program there, we changed this habit. So we start seeing a lot of Jehovah's Witness patients coming back to our society, our hospital. And every single department at our hospital try to use as much as possible bloodless or to reduce blood transfusion as much as possible. So they are trying to show some interest. We are also working on some viscoelastic testing to be in the OR, in the OP-GYN available for more testing and stuff. So more to come. I think we will help improve hopefully the AI for the future.
That's good. So the main things we're encouraging from the society per se is to encourage practitioners to move away from the term Jehovah's Witness as a primary initiative for bloodless, to just move to saying bloodless medicine is a safer practice and a better practice.
Exactly.
We try
Regardless.
to do in our clinical practice as well. So like Jehovah's is one indicator, but the biggest indicator is avoid transfusion. I think you've done a wonderful job.
Exactly.
So that's good. Any other questions, Melissa? If somebody else has one, or we move to the next
We
one.
just had one in the chat. Did this patient have prenatal anemia management?
I'm sorry, what was the question?
There was just one question in the chat. Did this patient have any prenatal anemia management?
It wasn't very well known. I mean, the patient
Be careful with your tone.
I'm sorry.
I think there's an accidental overtone by somebody. That's okay.
Okay, so it wasn't very well followed before the time of the delivery. I mean, she came really very close to her delivery.
There's one more question, I think, Melissa, I think.
Yeah, we did discuss. I can see the last question. So we did discuss with her to follow up on her iron deficiency anemia, and we encouraged her to follow up with her primary care physician to follow up on her anemia. But as of today, I don't know what's her hemoglobin or what's she doing. To be honest with you, I'm very sure she's gonna come one more week before her next pregnancy.
Good. So if no more questions, can we move to the next speaker, Melissa? Do we have Lynn Manley today? I was told they may not be able to make it. If
I do see her in the queue.
Okay, so I think if Lynn Manley is not there, I think we'll go to the next speaker, which is Andre, hopefully I spell it right, Bourgoin, who's a bloodless program consultant at Chicago Medicine, Chicago. He's going to talk about a very interesting, successful double lung transplantation with a blood transfusion, demonstrating the clinical efficacy of bloodless medicine and surgery. Over to you, Andre.
Well, first off, I'd like to say thank you for allowing me to be a part of this conference and to present this abstract. So many distinguished speakers today. We've learned so much. On behalf of Pablo Sanchez, a physician who performed this procedure, I'm privileged to share this abstract with you. This will no doubt demonstrates the clinical efficacy of bloodless medicine and surgery in complex cases such as double lung transplantation. So this was done without blood. And again, it just demonstrates the efficacy of bloodless medicine and surgery. We think about thoracic transplantation because of the great number of blood loss. We know that blood transfusion is traditionally used in an attempt to sustain oxygen delivery. We realize that now clinical evidence shows that that is not the case. Oxygen delivery is actually greatly reduced with donor blood. Thus, transfusion-free management can lead to superior clinical outcomes, and this abstract will demonstrate that with this double lung transplant that took place at the University of Chicago Medicine, February 19th, 2025, without donor blood, using comprehensive blood conservation strategies. Now, just give you a little background about this patient. For decades, she dealt with breathing issues. She battled reoccurring pneumonia, shortness of breath. So no doubt her lifestyle had changed dramatically. In 2023, she was diagnosed with stage 2 pulmonary fibrosis, and this led to irreversible lung scarring. So now she needed ongoing continuous oxygen 24 hours a day, quite limited now. So she's basically sitting, lying down, and a visit to the hospital, usually hospitalized about every 2 months. 2024, she received bad news based on the accelerated progression of the pulmonary fibrosis that she only had approximately 1 year to live. And she was in need of a double lung transplant. And so she was placed on the transplant list. What made this a challenge, though, is they had good medical facilities where she was that could perform a lung transplant, but she wanted it done without donor blood, which made it quite challenging. So no doubt she was rejected by those institutions there, as well as in some in New York. She learned of Pablo Sanchez right around December, January 2025. She talked with him. He reassured her of the efficacy of this particular surgery, how it could be done safely and also without the use of blood. And so hearing that, she agreed to come in. She was admitted at the hospital, University of Chicago Medicine, under the care of Dr. Pablo Sanchez. Her hemoglobin levels were 13.4. Now, we know the number one pillar of bloodless surgery is optimization of the blood. And so she received a protocol which included Epigen, about 15,000 units, 13 days. So there was a period of about 9 days where she received the Epigen every day. There was about a 2-day layoff, and then it was resumed for another 3 days. In addition to B12 injections, IV iron, folic acid. And because of being frail, there was a need for really giving some attention to her nutrition to support the increase of iron stores. And so as a result of these optimization protocols, this patient, the day of surgery, had a hemoglobin of 15, which was outstanding. In her operative phase, Dr. Sanchez and his team really recognized the need for oxygenation, conserving the patient's blood. So ECMO was used to provide that. As we know, it conserves the patient's blood. It allows ultra low blood loss, provides hemodynamics stability. And this is important for a surgery like this. It's a 10-hour procedure. And so the ECMO device really allows the surgeon the time needed to perform this complex procedure in a safe manner. Cell Saver, of course, was used to conserve the patient's blood. Heard some really nice thoughts from Dr. Species. Hope I'm pronouncing that correctly. But he gave us some nice thoughts around Cell Saver, which was certainly used in this case. And careful surgical techniques, hemodynamic control, of course, minimized the blood loss. So this was the intraoperative phase. Post-op management after the procedure, the patient continued on Epigen, again, to stimulate red blood cell reproduction, about 15,000 units, still with the 13-day. IV iron, B12 for hematologic recovery. Patient still had stable hemodynamics, along with progressive pulmonary recovery, all without blood. The patient was discharged post-operative day 27. Her hemoglobin was a 93. One beautiful thing about this, and speaking to the patient, she's resumed her regular lifestyle. She's walking, and like a woman, she loves to shop, so she can walk for long hours. Now she's tiring out her husband as they shop. She's able to play and really resume more activities with her grandchildren. She lives here now in Chicago in a 2-story building, so she's doing a lot of exercising by walking up and down the stairs to open doors, wash clothes, and so forth. What's the conclusion? Well, this case here demonstrates the safety and clinical superiority of bloodless medicine in surgery. The successes were achieved in a number of ways. First, optimizing the patient is always key. Getting the red blood cell hemoglobin level up high. Intraoperative ECMO cell salvage was used. Coordinated post-operative management. And of course, the multidisciplinary approach, which includes the coordinators of the bloodless program and so forth. So this case, this abstract alone really just reinforces, really helps to show the viability of bloodless transplantation for even some of the most complex cases, such as receiving a bloodless lung transplant. Thank you.
Excellent talk, Andre. Congratulations to you and Sanchez's team for carrying out such a high risk, what we call a lung transplant, and with showing successful outcomes. Let me see if any questions are popping up at all.
And we have Pablo on as well, Dr. Sanchez, to assist with this as also.
So I'll kick off the first question, Andre. So I worked in transplant in UK before, and obviously I presume this was a cadaveric transplant program you have in, was it right? Is it a cadaveric transplant program this was?
This was a brain dead donor. Good morning.
Good morning, Pablo. So my question was, how do you plan an optimization for the general attendees that if we don't know when the organ would possibly come?
Yeah.
So do you have a weekly follow-up of such patients to optimize the blood level, or do you have a protocol in place until you get the lung? How do you keep that going on? That's what I wanted to.
Yeah, so this lady, she's from Florida. Actually, almost a year out now, and she's going back to Florida soon. So she flew to us, and when she landed, she was so hypoxemic that she was taken from the airport to an emergency room. An emergency room, they were able to stabilize her with high flow oxygen and so on and so on. So we knew that she was gonna admit to us and stay in the hospital until the day of transplant. To the point that she admitted on December, I think, or something like that, or 24, and the transplant was at some point in February. And during the period of time, we realized a few things. One is that she could only get a double lung because she had pulmonary hypertension, so a single lung wasn't an option. Two, that she's 69, and she was, she had this diagnosis for a while, so she wasn't in the best medical condition. So it took us 3 months in the hospital to build her back. And in the hospital, she was, I think, in 40 to 50 liters of oxygen all the time. We worked on her nutrition. We worked on her. The hemoglobin part was only one of the aspects that we had to work on. We worked on her rehabilitation. And then she went into this level lung looking the best that she could look. But, if you see her, actually, she's tiny. She's this little tiny lady that barely look like she has some muscle left. So I think our rehabilitation team, our nutrition team, our bloodless surgery team, all teams that we have here at the University of Chicago did an excellent job. They got her all set for the surgery, and then she had a relatively safe surgery and a good post-op care. She got a good set of lungs, so she didn't develop any graft dysfunction. So there was no need for ECMO post-op. And then the team here in Chicago, you probably saw already Dr. Jivananda's talk early this morning. It's a team that is used to doing a lot of bloodless surgery. So one of the things to start getting people used to not drawing a lot of labs, getting used to make decisions with less information, which sometimes it's what takes the most to get support from all these other teams that are taking care of the patients. That you don't need 4 blood draws a day, to take care of this patient. And so that's eventually what happened.
So there's one more question on the thing. There was an exception by insurance to cover EPO with hemoglobin over 13 grams. Oh, someone answered
Well,
it.
she didn't. So she once I think she got to 13 grams, we stopped the EPO, but she continued with folate and iron. And after surgery, actually, we were significantly more liberal. I think she only got 2 or 3 doses of EPO, and she discharged with a hemoglobin of 9. So we're not really pushing hemoglobin after surgery. We actually have a transfusion limit trigger of 7 for our other cases. So it's like for people that can get transfusions, even we very, very, very we have a very low trigger to transfuse them. So we don't. If you had a hemoglobin of 7, 8, 9, we don't really do anything other than supplementation. Not even EPO sometimes. In her, it was just because, to be very honest, is the first Jehovah's Witness lung transplant done here at the University of Chicago. So I think everybody was like very sensitive that everything was going to go very well. So I think that's why maybe she got some EPO post-op. I think she probably could have gone without it.
There's one more question by Clement saying, there's a great job, Pablo and team.
Thank you.
What about the other institutions that rejected her? Did you give them feedback and possibly what they could have done differently to admit these category of patients in the future?
Well, we didn't give them feedback. No. Sometimes it's difficult to give surgeons feedback.
I can go with that one, yeah.
So I think we are working. So I've been doing bloodless lung transplants since 2021, And I think the only way that you can encourage, it's about publishing your results. So we have a publication in the Journal of Cardiovascular and Thoracic Surgery of 50 double lungs bloodless in 2023. And now we're working on publishing this case. So that, I think, is probably the best way to show others that is feasible and that is not, it doesn't require absurd infrastructure. It just requires a team that wants to work, making this possible. So, yeah.
So I think there's one more last question. One person I'll make a double question. One is, how long does the pre-op phase take? Which means, how long would you wait before pursue surgery? Secondly, from a surgeon to surgeon, do you do anything differently in Jehovah's Witness patient surgery, which you do not do in other patients, for example? So is there any special precautions or surgical techniques you modify or manipulate to make your outcomes better?
Yeah. So from the time that somebody is referred to us for an evaluation to the time they're listed, it takes around 2 months. Okay. From the time they get listed to the time they get transplanted, it takes an average, some people go really fast, some people go a little lower, of 40 days. And then as an average, people stay in a hospital 3 weeks after a double lung. That's kind of general numbers. In regards of
the surgical technique.
The technique, I think it has, so the technique, we aim to do all surgeries bloodless. So that's kind of has become our way of working. And tomorrow I had the pleasure of showing you a little bit of this. The whole idea of doing bloodless surgery, it got triggered with the intention of improving outcomes. I'm a firm believer that every unit of blood that you give that patient actually makes the outcome worse. So the whole goal was to offer bloodless to all. So we don't do anything different. We believe that the patients are the same. So we approach every single patient as a bloodless patient. Of course, there are some circumstances when you have a tough dig out, you have redo surgeries or previous transplants or then, some. I used to have a mentor that used to say, even when you do everything right, things can go wrong. Sometimes you still do everything right, and something happens that patient might need a unit of blood. But we aim to do everything bloodless. No, nothing different between patients. Yep.
Okay. So I think I'll leave the final words. Thank you, Pablo, and thank you.
I think somebody has their hands up.
Probably I have a question.
Yeah.
My question is, sorry, one sec. Yep. Dr. Sanchez, my question is, how long usually a bloodless procedure take with you versus non-bloodless procedure? Because when I talk to my surgeons and encourage them about bloodless procedure, they take it take longer time, more hours than usual, and that's what prevent them sometimes. And that's why they do the good job with Jehovah's Witness, but they don't do it with everyone else. To the point that we are getting patients right now, they are claiming they are Jehovah's Witness just to avoid transfusion, and they are not Jehovah's Witness for sure. So how long these procedures usually differ in time between bloodless or non-bloodless?
I honestly think bloodless is shorter, at least because, for example, when we were doing to be able to do bloodless surgery, we had to lung transplant. We had to change our hemodynamic support strategy. So before we used to use a lot of heart lung machines, cardiopulmonary bypass. Now we're using a lot of ECMO, and then we migrated to non-heparin ECMO. So we absolutely don't anticoagulate these patients at all when they're connected to ECMO. So when I take them off ECMO, I don't have to do anything. The patient is dry. When I was doing in cardiopulmonary bypass, I would spend the next 2 hours correcting the coagulopathy. So to me, actually, a bloodless surgery is shorter. And in that manuscript that I was talking about, the one in 2023, I think we show there that actually our bloodless transplants are at least 1 hour shorter than our non-bloodless.
Right. Yeah. Thank you.
just to support that, Majid, I think I'm a cancer surgeon. We do high-tech surgeries and all. So one of the things we try to say is, I guess Pablo would agree, we make every surgery as a standard surgery, which is bloodless surgery. So there is no differentiation between a bloodless or a bloody surgery, if you want to call. So I think once we do everything standardized, the need for transfusion will automatically drop. I think Pablo may high-five on that. Good. So Melissa, I think I'll hand over to you for the final words, Melissa.
Yeah, that was two wonderful abstracts. Thank you to all of our presenters, also all of our speakers this morning thus far. We thank you all. And we would like to introduce Rebecca Rock and Gary Koenig, who will introduce us to our next session on blood tech.
Good morning, everybody. Thank you so much for joining. And I hope you've enjoyed day one so far with all of the wonderful speakers and those great abstracts that we've had. I'm happy to introduce our last session of the day titled Blood Tech. My name is Becky Rock, and I'm a registered nurse who is the clinician and the coordinator of the Patient Blood Management Program for Alberta Health Services in Canada. And I'm pleased to co-moderate today with my partner, Gary Koenig, who is a seasoned perfusionist with over 30 years of experience, and he is the president and CEO of Comprehensive Blood Management Incorporated in the United States. Hi, Gary.
Hey, Becky, thank you so much for that wonderful introduction, and I appreciate being asked to be a co-moderator today. Welcome everyone to this wonderful conference and all of us who have a passion for patient blood management. I'd like to introduce our first lecture, When Every Drop Counts, the role of POCT in bloodless medicine, and our speaker, Dr. Caitlin Raymond. Dr. Raymond is Assistant Professor of Pathology and Laboratory Medicine at the University of Wisconsin-Madison and a transfusion medicine physician. Her clinical practice spans blood banking, apheresis, and cellular therapy, with a strong emphasis on patient blood management and reducing iatrogenic anemia. Dr. Raymond's scholarship focuses on pragmatic, data-driven improvements in transfusion care, including total blood volume estimation in obesity, platelet microvesicles, and right-sizing component therapy. She also works at the interface of informatics and quality, translating frontline needs into usable tools and cleaner EHR pathways, therefore improving efficiency and safety. She advocates for meaningful operational metrics such as diagnostic turnaround time that link laboratory performance to patient outcomes. She completed her MD, PhD in medicine and neurobiology at the University of Massachusetts Medical School, a clinical pathology residency at the University of Texas Medical Branch, and a transfusion medicine fellowship at the NIH Clinical Center. Her work has been recognized by the American Society for Clinical Pathology's 40 Under 40 Award. Outside of the lab, she writes about transfusion medicine and systems improvement on her site, Blood, Bites, and Beyond. Today, Dr. Raymond will discuss point-of-care testing as a tool to minimize phlebotomy and support bloodless medicine, translating everyday process changes into safer, more patient-centered care. Welcome, Dr. Raymond.
Thank you so much. That was a very enthusiastic welcome. I really appreciate it. I'm delighted to be here today. Can everyone hear and see me okay?
Very well.
Wonderful. I see some nods. Okay, great. I'm going to share my screen. And are you all able to see my slides?
Not yet. We can. Yep.
There we can.
Yep.
Okay, now you can see my slides. Okay, great. So I'm going to be talking about the role of point of care testing in bloodless medicine today. And I know we're running a little bit behind, so I will try to make up time as I can. This is Devil's Lake out here in the driftless area of Wisconsin. It's a beautiful site with these wonderful like rock formations out sort of in the middle of nowhere. I've actually hiked around it, and this slide is just to let you know that I have no disclosures for this talk. The learning objectives that I have for you today are to talk a little bit about the mechanisms and clinical impact of iatrogenic anemia, then to differentiate between point of care testing and traditional laboratory testing, and then evaluate the evidence supporting specifically point of care testing as a blood conservation strategy, and then to talk a little bit about the limitations and opportunities of point of care, especially in terms of accuracy and interoperability. So how does this fit into bloodless medicine and surgery? So the goal of bloodless medicine and surgery is to minimize or avoid blood transfusion. And this involves minimizing blood loss, optimizing oxygenation, optimizing anemia, and then also just blood conservation. And we've already talked about that a lot this morning, so I won't go too much into it. One thing that we don't often think about is that in addition to blood loss from procedures and anemia, we also have blood loss just from diagnosis. So for example, an ICU patient loses on average 30 to 50 mLs of blood for diagnostic lab tests every day. So, you get that daily CBC, you get that daily BMP, all of that draws a few mLs at a time in a tube. And in a really intensive setting like the ICU, it adds up over time. And so that adds up to about a unit of blood every 8 days that we draw simply for diagnostic lab testing. And this is the underpinning of something we call iatrogenic anemia, or medically induced anemia. So this is iatrogenic anemia, which is caused by medical procedures, in particular blood draws for diagnostic testing. Iatrogenic anemia is kind of a buzzword right now. A lot of people are writing about it. A lot of people are writing about how to manage it, including optimizing blood draws, so using pediatric tubes or smaller tubes, and managing blood draws so that they occur at the same time, so that they're not happening just throughout the day. Closed blood sampling systems are where you don't draw excess waste of your blood. You only take enough that you need for the test and then return the rest to the patient. And then conserving blood draws, so only sharing samples, only doing necessary tests. But there's something else that is used that's being investigated for iatrogenic anemia, and that's using point of care testing devices. And so we're going to focus on this today as one of our mechanisms for reducing iatrogenic anemia in support of our overall bloodless medicine and surgery goal. So what is point of care testing? It's just testing that occurs at or near the patient. And there's a couple of examples. These are things that people do at home. These are point of care tests. Glucose testing and pregnancy testing are both things that happen at home. But there's also things that happen only with providers, or mostly with providers. And those include hemoglobin, hematocrit through like a microtube, and even troponin has a point of care platform right now. So these are all testing that occur at the bedside. So you don't have to draw a sample and send it to the lab and wait for results. You actually do it at the bedside and get immediate results. It is a little different, though, from traditional laboratory testing in ways that are both, great, and also some limitations of the platform. So first of all, laboratory testing, an average sample volume is 3 to 5 mLs, whereas point of care, it's in the range of 100 to 250 microliters. So we're talking, a factor of 10 lower. Turnaround time for point of care is minutes, whereas for laboratory testing, it could be hours to days. The type of test performed, laboratory testing, there's a really wide variety of assays that can be performed. Point of care testing is often colorimetric assays. Point of care testing has more operator dependence. And it also has a limited test menu. So there are some tests that are simply not in a point of care format. And then the other limitation of point of care is that it may require confirmation. There is some evidence that, it's not as accurate, and so you may need to confirm the results with another laboratory test. So it does use smaller volumes, it allows faster decisions, and it can allow us to optimize preoperative management and optimize chronic disease management. And so all of these are ways in which point of care can help iatrogenic anemia. but has it been proven to actually help in iatrogenic anemia? And in order to do this, what I did is I looked through the literature for studies that focus on point of care testing alone as a single intervention. Point of care testing is often included as a bundle of interventions to reduce iatrogenic anemia. And as a bundle, it's been repeatedly proven to reduce iatrogenic anemia, to reduce diagnostic blood loss, and even blood transfusions. But if we isolate it out, do we see that on its own it has an effect? And so I found some studies in neonates in the NICU setting that show that RBC transfusion number and RBC transfusion volume both were reduced after introducing point of care testing. And so that's a powerful finding that I think that we could extrapolate to adults. And then there was this study showing that by birth weight category, the gray bars are after post point of care testing was introduced. And you can see that the transfusion rate pretty much dropped for especially the low birth weight babies. So especially the most vulnerable, most delicate patients, they really had a drop in the amount of transfusions that they needed. And so it sort of had an outsized impact on our most vulnerable patients. There are some studies in adults as well. So I found this review that found that there were 2 studies where volume of blood loss and risk of transfusion were both reduced or decreased after introducing point of care testing in an adult population. And so there's evidence for both neonates and adults that point of care testing does indeed reduce iatrogenic anemia and the need for blood transfusion. So that sounds pretty great, right? Like, why aren't we all switching over to point of care testing right now? Well, there's some limitations to point of care testing. Like I said before, it has some limitations in accuracy. It doesn't always reproduce the same values as you would have on a lab test. There are some limitations in interoperability, and then there's also operator variability. I know that I only have so much time to talk to you today, so I want to focus on these 2 aspects of the limitations of point of care. And so the first aspect is accuracy, and some of that has to do with the actual type of blood that we're sampling in point of care. We're not taking venous blood, we're taking capillary blood. And so it's collected from skin capillary beds. Especially with coagulation testing, point of care samples, that capillary blood, can be contaminated with tissue factor and can affect coagulation results. And then there's also been a lot of studies done about point of care hemoglobin. The mean value is higher with greater variability, and I'll show you that here. So hemoglobin measured in venous versus capillary blood, if you look, pooled capillary blood has a higher mean with a greater spread. Whether it's pooled or single drop capillary, that's true compared to venous. So a higher mean and a greater spread of values. And so the platform itself may need confirmation, and that is a drawback of point of care testing. There's also the issue of interoperability. So what does that mean? That means how data flows from the actual point of care device into the electronic health record. So I'm going to go over a few different types of data flows. And the reason I'm going to do this is not really to torture you with some confusing slides. It's to prove to you that there's a lot of variability and it can be very confusing. So this is one data flow where data flows from the point of care device to middleware, then to the laboratory information system, then to the EHR so clinicians can see it and integrate it. And then there's another data flow where data from point of care goes to the middleware and gets pushed to both the LIS and the EHR at the same time. Or it might be that point of care goes to middleware, goes to the EHR. The EHR sends orders directly to point of care. It gets very confusing. There's a lot of different variations of this. And then every single point of care device itself has a different platform. They're all proprietary. The company that makes the device, does it interact with your middleware? Can it talk to your LIS? Can it talk to your EHR? It gets very confusing very fast. And then a lot of people will already know this, but who owns the point of care device? Does it belong to the lab? Do we maintain it? Do we do all the maintenance and teach people how to use it, or does it belong to the clinical side? It gets very confusing very quickly. It's a relatively newer type of testing, and I think that who owns it and how it gets integrated into the system is still very much being worked out. And so that's the point I'm trying to make here is not really to confuse you, but just to show you how confusing it can be. Point of care data flows, they really are complex, and interoperability remains a significant challenge, maybe the biggest challenge to incorporating more point of care testing modalities. So transitioning now towards the end of my talk, I want to talk a little bit about the future point of care and bloodless medicine. I know it's a newer testing modality, but I really think with time, smarter integrated connectivity with EHRs and LIS will come about, and it will be less burdensome to onboard a new point of care testing platform. I also think there will be expanded test menus via miniaturized platforms. There's already been a lot of research done on this. I think that will continue, and eventually we will see that a lot of the tests we can only do in a lab right now will become available on point of care. And then there's also the possibility of bloodless point of care. Can we do testing at the bedside without any blood? And yes, we can. Specifically right now, what I wanted to focus on is non-invasive hemoglobin monitoring. Using spectrophotometry, you can actually monitor someone's hemoglobin along, like, just by attaching a sensor to their finger. Are there drawbacks to this? Yes. I'm not going to go in depth on this particular testing modality today, but the technology is rapidly advancing, and in the future, we may be able to test someone's hemoglobin very readily at the bedside in a very accurate, reproducible way without drawing any blood at all. And so that's coming, and it's, these machines are already on the market, and I think that they're going to be, integrated more and more as over the next 5 years. So just to come back to my learning objectives and summarize here. So 1, point of care testing utilizes smaller volumes and allows for rapid decision making. It's been shown to reduce diagnostic sample volume and transfusion requirements in both neonatal and adult populations. The limitations of point of care include accuracy and interoperability. And the potential of point of care testing is really growing. So with better integration and new miniaturized platforms and bloodless POCT, we're going to see like a whole spectrum of tests become available. And then the one thought I'll leave you with today is when every drop counts, make every test count. So in support of our pursuit of bloodless medicine, let's make all these tests really count. And with that, I will take any questions.
Thank you so much, Dr. Raymond. We're going to do the questions at the end of both speakers for this session. Yeah. So I'm going to introduce our next speaker, and I'm going to invite him to load his slides while I do his introduction. Our final speaker for this session is Kevin Fleming, who's a chief perfusionist at ProMedica at Toledo Hospital, and with over 30 years of experience in the field of cardiovascular perfusion. Since implementing TEG technology in 2009, the cardiac surgical team with Kevin has made marked improvements in blood utilization and enhanced patient outcomes. By leveraging TEG guidance, their team has been able to move away from traditional empiric transfusion decisions to treat coagulopathy, and this ensures that patients receive more precise and effective care, tailoring to the patient's individual needs. Kevin has co-authored several publications sharing ProMedica's experience with utilizing TEG to reduce necessary transfusions and advancing the quality of patient care. So today, Kevin will speak on enhancing bloodless care, the role of thromboelastography, or TEG, in optimizing patient outcomes. Welcome, Kevin.
Is it working?
Yeah, I think if you just want to put it on slide mode so it fills the screen, or slideshow mode up at the top.
Sorry.
Yeah, no problem. So just if you want on your top next to animations slideshow up in your top toolbar, way over on the left-hand side, yeah, see slideshow, and then next to animation slideshow, yeah, and then once you select that, and then go from beginning on the left-hand side. Yeah. Perfect.
Good.
Thanks.
All right. Well, good morning. Thank you for having me. My name is Kevin Fleming. I'm the Chief Perfusionist at ProMedica Toledo Hospital. Today I'm going to be talking to you about how we use TEG thromboelastography to guide hemostatic therapy to optimize patient outcomes and bloodless care. This is our hospital. This is where I work. Toledo Hospital was established in 1874, so 150 years ago. You can see how it has dramatically changed over the years. We've evolved into a nationally ranked hospital committed to clinical excellence for the communities we serve. Toledo is also known for the great Toledo walleye, the Toledo mud hens, and also one of Klinger's favorite restaurants on MASH, Tony Paco's. So I wanted to give you a little background of our cardiac program. We do 850 plus open heart procedures a year. Around 50% of these cases are considered complex, double valves, valve cabbages, aortic dissections, redos. So we do a lot of complex cases. Coagulopathy can be elusive in these cases, and many cardiac teams rely on an empirical, unguided transfusion practices, as we did as well, or we used to. Often it's termed the shotgun approach, and that is where basically you would just give, if a patient's bleeding in surgery, you would just give 2 FFP, 1 or 2 platelets in cryo to try to correct the coagulopathy. 15 years ago, in 2010, understanding the risk-benefit paradigm of transfusions, we wanted to move away from these unguided transfusion practices to eliminate unnecessary transfusions and their associated risks. So we implemented point-of-care TEG technology to guide our transfusion practices, and we have had great success reducing patient transfusion exposure. We have an awesome, robust patient blood management team that does a great job with pre-op optimization. We have been a significant referral center for Jehovah's Witness bloodless care patients. We have done many bloodless complex cardiac surgeries. I would say 300 to 400 with no mortality. Dr. Morant, our surgeon that does most of these surgeries, will be speaking tomorrow, and he has a great talk on how we do things. TEG integration into bloodless care protocols has enhanced our ability to deliver safe and effective optimized patient care. So what is the TEG? It's a point-of-care diagnostic test that provides near real-time assessment of whole blood clot dynamics throughout clot formation and breakdown. So it provides a global assessment of the efficiency of coagulation. How it works with less than 1 ml of blood, it evaluates the coordinated function of coag factors, platelets, and fibrinogen as the clot develops and stabilizes. So you're looking at the rate, strength, and stability of clot formation to determine the risk of coagulopathic bleeding. This test can also look at thrombosis. We used it a lot for vascular patients that have recurring DVTs, and it's able to, by looking at all the clot dynamics, it's able to look at risk of thrombosis as well. It generates a graphical profile of clot formation that pinpoints defects in achieving a stable clot. To the right are the hemonetics. We used the TEG 5000 in the upper picture for 15 years. We are now transferring over to the TEG 6S. below. The upper model was a cup and pen with pipettes, so the 6S will make the platform much easier with cartridge-based TEG testing. Also, there's other devices on the market, such as Rotem and the Quantra. So we feel that the TEG is the key to safer, smarter surgery. It arms the physician with timely knowledge to guide targeted transfusion practices and alternative hemostatic therapies for bloodless care patients. In other words, it provides a compass for directing our transfusions and is able to guide our blood management practices. This results in reducing unnecessary blood product use, transfusion exposure, and we have greatly improved patient outcomes. You end up with goal-directed, individualized patient blood management therapy with this technology. Just to go over a few things. I mean, traditional lab tests have they're very important tests, but they have their challenges. They provide a limited view of hemostasis. They're plasma-based with static endpoints, whereas the TEG is whole blood analysis. There's no randomized controlled trials supporting use of actually using these tests to guide coagulopathy. It does not adequately explain the hemostatic process that occurs in vivo, whereas TEG technology looks at the dynamics of clot from initiation, propagation to breakdown. As mentioned in the previous presentation, that was really great. You may have significant time delays with traditional lab testing versus point of care TEG testing. Here at my hospital, it is managed and run by the perfusionist. So monitoring hemostasis with the TEG. This is their platform. The TEG 6S is cartridge-based with 4 independent channels. I would like to say, don't be surprised by the TEG 6S and the noise it makes. It sounds like humpback whales communicating underwater. These are servo sounds and part of the operation, but when we first heard it, we thought, wow, what is that? The 6S provides easy to understand numerical data as well as the graphical clot profile. They'll output measured parameters, RK, angle, MA, and lysis. Think of the tracing. I like to think of the tracings on the right kind of as an EKG of the blood, examining the dynamics of coagulation rather than electrical activity. It outputs parameters like an EKG outputs its parameters. So I think that's a good analogy to say it's like an EKG of the blood. So the 2 test cartridges, not to get too involved, that I'm going to go over are the Global Hemostasis HN cartridge for cardiac surgery and also the platelet mapping cartridge. So it has 4 independent channels. There's 2 Kalon tests that look at coagulation factors and anticoagulation. And the other 2 look at platelet and fibrinogen contribution, the rapid TEG and the functional fibrinogen. All 4 of these tests are critical to deciding what blood products need to be used to pinpoint coagulation deficiencies, and also it helps us with our alternative bloodless care decisions. Platelet mapping. This is a really great test. I can't understate how important this has been for us. It's a comprehensive platelet function testing cartridge performed on the TEG 6S platform. It can look at an individual's platelet function in response to antiplatelet medication, which we know can vary among people. I mean, there's 30 to 40% of patients are non-responders to Plavix, but it monitors things such as Plavix, Effient, Brilinta, and aspirin by looking at the ADP pathway and the AA, arachidonic acid pathway. It can really inform clinicians on how therapeutic their patients are on these antiplatelet agents. With that information, it's really important to understand that platelet count doesn't equal platelet function, and that everyone has different everyone has different underlying platelet functions. Some people are hypercoagulable, some are hypocoagulable. So when you look at different testing for platelet function, knowing the percent inhibition just isn't enough, because it's nice to know the maximum platelet function of the patient, which the tag can show you as a reference point. So patient A shows you someone who's very hypercoagulable. If their antiplatelet activity reduces them by 50% function, they're still going to be hypercoagulable. Patient B, who has less of a baseline platelet function than patient A, when you reduce them by 50%, they become therapeutic in the normal range. The patient C's are the ones we worry about, that they have normal underlying platelet function. They're on an antiplatelet agent for whatever reason, whatever clinical reason. And when you put them on an antiplatelet, they become severely hypocoagulable. These are the patients with pre-op assessment are very important to find out, because they're going to have a very high risk of bleeding compared to the others. So I just wanted to show you this. This is kind of how the graft is generated for clot strength. That's kind of how the graft grows. And you're going to have functional fibrinogen, and then you're also going to have the MA platelet and fibrinogen contribution. So this looks at the difference. It looks at the fibrinogen contribution to clot, and it also looks at the contribution of platelet and fibrinogen together. 80% of clot strength is usually made up by platelets. So this is a graphical representation of the TEG parameters. You have the R, K, angle, MA, and lysis 30. The R demonstrates reaction time or clotting time. So this is your clotting cascade working to produce thrombin. The thrombin burst is a pivotal point of coagulation. The K looks at the amount of time it takes to develop an MA of 20 millimeters. So it's kind of a predetermined, gives you a little bit of a heads up. The angle looks at the kinetics of clot development. The MA looks at overall clot strength. And lysis 30 examines the stability of a clot. So with that information, RK, angle, and MA, we are able to determine what products are needed, especially in a bloodless care strategy. So if you have a long R and you have ruled out anticoagulant effect, you could use a PCC or recombinant factor 7A. We do use that on our majorly complex cases. The angle will tell you whether or not a fibrinogen concentrate or rheostat can be used, or if the patient accepts cryo. The platelet MA will let you know about whether or not you should use DDAVP or poor platelet count pre-op. We have used M-plate. You give that like 2 weeks prior, and we have brought patients up from abnormal platelet counts to a normal range to make them safer for surgery. And then clot instability, the need for Amicar, tranexamic acid. With traditional blood guidance, we would use a FFP, cryo, or platelets for the MA compared to bloodless strategies. So the TEG success guided bloodless therapies, then I made this this chart here based on like the R parameter. If it's greater than 9 on the CKH, after you rule out anticoagulant interference, you have a coagulation factor deficiency, so you could use prothrombin or factor 7. Your functional fibrinogen, if it's less than 15, you have a fibrinogen deficiency. MA is less than 50, platelet dysfunction, you can use desmopressin, interop. Lysis 30, if it's greater than 3.2, you have hyperfibrinolysis, so you need to use tranexamic or Amicar. And then platelet mapping pre-op, if the MADP is less than 50, you probably should wait a few more days before surgery. You should increase your wait time for surgery to decrease the risk of intraoperative bleeding. And the big one for us is the RCK and RCKH difference. This lets us know if heparin is still present. We have to use a lot of heparin on bypass. And if it's inadequately reversed, we're going to have continued bleeding. So you would need to give 50 milligrams of protamine, usually 50 to 100. The first thing you want to ask before you look at any of these parameters and their results is, the first question you always ask yourself first, though, is the patient bleeding? We never just treat numbers. Applying the tag to our system. Bloodless medicine is a comprehensive multidisciplinary approach to patient care that aims to minimize or eliminate the use of allogeneic transfusions. Key to success: apply multimodality interventions aimed at preserving the patient's own blood volume and hemostatic balance. So we always felt like we had a missing piece of the puzzle. Over the years in cardiac surgery, we've always sought to improve our blood management practices. And by employing multimodality interventions, you can minimize the need for blood products or alternative hemostatic agents. So preoperatively, you can have different therapy adjustments, pre-screen for anemia, iron EPO therapy, which our blood management team does a great job of here. Intraoperatively, Dr. Morant performs a lot of minimally invasive surgeries on JW patients, fluid management. We have biocompatible circuits for our heart-lung machine. We use intraoperative cell salvage, ANH, various hemostatic agents, point-of-care testing such as the TEG. So you can see what how many different modalities are needed to be successful at doing bloodless medicine. And post-operative, we have fluid management and maintaining optimal hemodynamics. What about the TEG? The TEG has entered all phases of our blood management patient continuum of care. The TEG has become a special arrow in our blood management quiver, allowing us to precisely target causes of coagulopathy with the right treatment. And our docs have been hitting the bullseye and tailoring responses to coagulopathy through real-time TEG-guided decisions. So this has been a great addition to our blood management arsenal. TEG has improved patient care delivery throughout the episode of care. Pre-op, we can have a proactive look. Very important to be proactive when you're trying to minimize the use of blood products. Proactive look at patient surgery, the patient before surgery, minimizing risk with the use of TEG and platelet mapping. Interop, we have goal-directed bloodless care and blood management decisions that we can make that are guided. We can ensure heparin reversal, and we can identify coagulopathy versus surgical bleed. This is especially important post-op. If you have a bleeding patient post-op, a lot of times we would take them back for surgery only to find that it was a coagulopathy. But with the TEG, we've been able to rule out needing blood bank blood components, and it might be something as simple as heparin rebound needing more protamine. So that has been very helpful with distinguishing between surgical bleeding and coagulopathy. And post-op hemostasis management, if there's any need for any other type of PCCs or fibrinogen concentrate, continued DDAVP, et cetera. In 2019, we published this paper in the Annals of Thoracic Surgery looking at the difference between our empirical transfusion in a population of patients pre-TEG versus post-TEG. And we had great results. This was a retrospective study and is very multifactorial, but our findings were that we had a significant reduction in patient blood product exposure. We had a significant decrease in rates of reoperation. Our post-op renal failure and pulmonary complications were significantly lower, significant shorter length of stay, and a significant reduction in patient mortality 6 months post-op. I can tell you that pre-TEG versus post-TEG, we reduced our FFP use by shotgunning blood products by almost 70%, for example. In conclusion, TEG testing provides rapid, comprehensive insight into coagulation. You can reduce unnecessary transfusions by identifying specifically what is needed to achieve hemostasis. Pre-op TEG and platelet mapping is a patient risk management game changer. We've been able to enhance bloodless care, and this technology allows us to pinpoint protocolized responses based on TEG-guided parameters. This equals goal-directed, individualized patient blood management, and we consider TEG as essential to the modern bloodless medicine model. So thank you very much. Thank you for having me.
Wonderful. Thank you so much, both to Kevin and to Caitlin. It was absolutely some interesting things to consider and all the different applications that we have for these incredible technologies. So we're going to open it up to question time. We've got, we're a little bit past the hour, but we've got a few minutes that we can answer any questions you have. In the Q&A box, that's where you can type your questions if you haven't already. Just so you know, within the Q&A box, you're going to see 3 different segments open. Those are the questions that haven't been answered yet. And in the answered segment, that's where some of the questions that have been posed have either been answered live or they've been answered by type. So if you're interested in seeing those and seeing what those answers were, you can take a look in that. So without further ado, let's go ahead between Gary and I. We're going to moderate some questions and then we'll wrap up today. So first of all, one of the questions was, can TEG be applied in oncology cases? Are there any limitations with that? And if you can comment on different perfusion available, I wonder if that's referring to some of the different options mentioned in the lecture. But for this, I wonder if we can focus on the point of care and the TEG question. Can it be used in oncology, or are there any limitations in terms of patient types?
No, there's not really any limitations. We've used it in all aspects, in trauma, OB, vascular, oncology. You know, a lot of cancer patients tend to be hypercoagulable. So there's been a lot of different uses, and we've just honestly over time have learned more and more about how this technology can benefit us, especially being at the point of care with real-time decision making. It's been a great adjunct to all of our therapies.
Gary, do you have anything to add with that too, from your experience?
Yeah, I'd like to ask Kevin a question. I know we've used a TEG for 20, 25 years. And one of the things, and it's been a few years ago, is when we would go to the unit, CVRU, and we would have significant bleeding, when we would, and this was a while back, we would have to send down our samples to the lab, because at that time the TEG was kept in the laboratory due to strict temperature requirements and everything. So Kevin, what's your turnaround time if you're in the unit and a patient's bleeding, and is the TEG available in the unit, or how quickly can you get your results back?
Yeah, we have the TEG available right now. It's in our pump room in between the ORs, but they call us, we go over there, we grab a sample. So I'm thinking within 20 minutes, we can have actionable data. My plan is to, with the Success platform, put a device over in the unit. And with the cartridge system, it's going to be much easier to expand the technology to ER, HV, ICU, et cetera.
Yeah, that was one of the things we realized. We wouldn't get our results back, or actually our products delivered for 45 minutes or so. And if you've got several hundred mLs of blood going out your TEG results, they differ, because now you've lost that much more blood. You're treating the results of the TEG at that time, but then you've lost several more hundred mLs of blood. So now what you may need component-wise may have changed.
Yeah, correct. I mean, things can rapidly change, as you know, and with bleeding patients like that. So, especially in small body patients, small habitus, they're even more rapidly changing just due to decreased estimated blood volume.
Okay.
Have you ever compared TEG to one of the other like similar platforms like Quantra in terms of turnaround time? Because I know Quantra was really pushing like bedside rapid decision making as part of their platform.
I haven't compared the two, but I know they're probably both equally quick. I haven't operated. I've seen the Quantric meetings. I haven't actually got a chance to use it. It would be cool to trial it just to see. I like looking at all the different devices, but I would think that it's pretty comparable.
Yeah.
If we could call on Sarah, she's got her hand raised. She's one of our panelists today, Sarah Wald.
Hey, Kevin. Thanks for the presentation. I really appreciated it. I know you have a robust bloodless care program, and the University of Chicago as well. I was wondering, do you feel that you approach surgical patients different, whether they come in as bloodless or the standard population? And if so, why? Do you approach their surgical plan differently?
I don't think so. I mean, we do A&H on our patients. We approach them. I just think the decision making, there's much. I will say that there's better pre-optimization for bloodless care patients. For the non-bloodless, you might see people come into the room with a starting crit of 30 if they're not a bloodless, if they haven't gone through the bloodless care pre-optimization. And I'm not sure that is something we have tried to address over the years, but it can be difficult when some of these patients come up as emergencies, et cetera. But they'll often start that process post-op, but it doesn't really help us much in the OR when you're dealing with a starting crit of 27 in the room. But I would say all other things are equal as far as all the modalities that I showed in that one slide. We do that for all of our patients.
Thank you.
I have a question for Dr. Raymond on point of care testing and a situation we ran into about a year and a half. We had a paper published in OB on C-sections and use of the cell saver comparing the hemoglobin and hematocrit. And we tried to get the HemoQ, which is a point of care device that measures hemoglobin. But in the hospital setting, it's like, who owns that? Have you run into issues where the laboratory or they didn't want to give it up? And so what we ended up doing for all those patients, we physically had to run our samples down to the lab and have them run stat, because as you know, in OB and C-sections, those cases are extremely quick. And we were trying to get results to make decisions on patient care. Have you run into situations where it's like territorial issues with point of care devices?
Oh, yeah. And that's very classic when you onboard a new point of care device, right? Because it doesn't live in the lab, it lives at the bedside. So who's going to end up owning that? Will the lab own the point of care device? Is the lab responsible for training the operators? Does the lab do the maintenance? Does the lab manage the result? And I've actually seen, I would say every single institution will have their own different policy, even within departments, of who's going to own the point of care device. And that's why I think interoperability is probably the biggest barrier to increasing point of care use in clinical, like everywhere, in every setting, inpatient, outpatient, OB, surgery. Who's going to own the device? And then also, how does that data get managed? I mean, I can remember when I was at UTMB, we had Quantras in the ICU, at bedside in the ICU. Isn't that marvelous? Well, we could never see the results of the Quantra unless someone running it took a picture and uploaded it to the media section of the chart. And if they didn't take a picture and upload it to the media section, we had no idea what the result of the Quantra was, because the Quantra wasn't actually connected to our LIS or our medical record system. And so a lot of those issues, the logistical issues of actually integrating a point of care device into your system is probably, I would say, the biggest barrier, more so than the poor, the smaller test menu or the different sample size or the different sample type. It's who's going to own the machine.
I agree. Thank you.
Yeah.
So if there aren't any more other questions that you see, Becky, or anything, I guess we'll bring the Q&A session to a close, running just a few minutes behind, but I would like to thank all of our speakers, panelists, the attendees, and co-moderators for today. And I also would like to remind everyone that we're going to start tomorrow's session again at 7 a.m. And I'd like to go over some of the talks we're going to have. We're going to start out with my BM session, Pillars of Bloodless Medicine. We're going to have our keynote address, Optimizing the Hematocrit in Bloodless Care, More Knowledge, More Technology. We'll follow that with the role of technology in minimizing perioperative blood loss, then optimizing tissue oxygenation and supporting patients' tolerance of anemia with and without technology. We'll follow that with our symposium of bloodless surgery techniques, minimizing blood loss in open heart surgery, technique, therapeutics, and technology, then robotic spine surgery, precision and elegance in bloodless surgery, and then our keynote address on bloodless lung transplant, a breath of fresh air for outcomes. And at the very end tomorrow, we will end with our industry and abstract presentations. I'd like to thank everybody for attending today and look forward to seeing you tomorrow.
Wonderful. Thanks so much. It was great to work with you, Gary. Thank you to everybody. And so just as a final wrap up, we're going to ask everyone to please turn on your cameras. If you are comfortable to do so, what we would love to do is snap some screenshots of everyone who attended today as a big thank you and as a big celebration of everybody who was on. So please put your cameras on, and somebody who is coordinating behind the scenes will snap the photos of all of the screens. So just hang on for a minute or two and we'll get those done.
Schneider, please let us know when you're done. I think Schneider, he forgot to tell us to smile. Please, everybody should smile. And keep it that way. Yeah.
I have it. We got it.
Okay, good.
Wonderful. Thank you so much. So we will officially draw today's session to a close. Have a good day, everybody.
Bye-bye.
Bye.
Thanks again. What a nice privilege. Thanks, Nat.
Thanks
Thank you.
again. Kevin, it was wonderful hearing your speech. So honored to have you.
Oh, thank you.
Yeah.